Italy.
Situation, we are optimistic, always optimistic.
Oh.
Things have to go better than today and slightly better.
Yes, we need to be optimistic because in this hard time, it's the only way to be not depressive.
No, Domenico, vogliamo prima? No, sorry, Naja, because I am engaged in problems with the clinic. Sandy, they want to see 2 slides.
Just to make sure that the connection is working nicely.
And Imad, I realized, okay, let's see.
Yes, we are seeing your slides very well, Paolo.
Okay.
You are on. Okay.
Seems to be working.
Wonderful.
Okay, like only one, no presenter tools.
Any other has joined from the speakers or not yet?
First, Rudolf Fabush, then Nelson Oyeshiku.
Is it possible to check Nadia's video? Can we check your video again? Because I'm not sure if you're Nadia.
No, it's working. You know, there is just in this type, there is some this is coagulation. So we have, but it's working. It's working good. Don't worry. But I saw here in the chat that Edward Rose can't join. You see it, Ahmed?
No, I don't see him yet.
No, he said he can't join us.
Who is?
Oh.
Who?
Why?
Yes. In the
chat. He's in the chat?
Yes.
Who is in the chat? Sorry.
Yes. And
Edward Laws from
answer.
Pablo, I send you a message.
Okay. I'm checking. Yeah.
Mad, where are you now? In Riyadh or in Dubai?
I'm still in the same place holding the flag. Yeah.
Let me see. Yeah.
Perhaps it doesn't make a difference nowadays where you are. You will get stuck to the place for.
Yeah, I was trying for 10
yeah.
minutes. I hope.
Ciao, Paolo.
Hi, Ed.
Finally, he's here.
I was having a swim.
Hi.
Okay, no problem.
I can see Ed Lowe's now.
Yeah.
All right. Very good to see you. All right. Do you want to check your 1 or 2 slide, Ed, from your presentation before we start?
I can share a screen and do that, I suspect.
Yes.
Is that correct? Okay.
Right.
Here it is. And
yeah, you are on.
Sure.
Very good. Very good. Thank you.
Okay.
Wonderful. Very good.
Okay, now stop share.
Yeah.
Ed,
I'm back with
you. I really admire your wonderful weather over the days.
Since I can see how
sunshine. Since
how Boston changed weather.
Yeah. You know, we have major snow today, right?
Yeah. Your scenery behind you.
Yeah.
That's what we admire. That's what we admire.
Oh, it's great to see you all. Thank you. Imad, thank you for organizing this for me.
It's a pleasure to have you all. Well, I think in a couple of minutes we will start and just see if everybody there, and I put the program. So we try to be strict with the time. So we will give a warning 1 or 2 minutes ahead of time. I would say 2 minutes. Then the speaker has to conclude. And so we'll give chance for 1 or 2 comments or short questions. So everyone has 25 minutes and 5 minutes extra for the questions.
Paolo, ciao. Ciao. Senti, volevo sapere a che ora devo venire secondo il programma. Siccome c'ho una roba internazionale, un webinar internazionale alle 4, va bene?
Ma è domani.
Va bene. Ciao, ciao. Ciao.
Ciao.
Is Nelson with us? Did Nelson join or not yet?
Quando mi faccio vedere quando sto parlando
If not,
Anyhow, I think we are not going to wait for anybody anymore because the time is ready. Is it 15:03? So we'll start at 15:05. But I'd like first to thank the members of this committee who has been very active. The chairman of the committee, I'm co-chair with Professor Benish. He has contributed tremendously to the success of this webinar and to our courses, and of course all the members. But specific thanks to Dr. Pablo Gonzalez, who was instrumental in distributing the informations and salvage the hacked website from last night to be on the web today on time without any problem. So I repeat myself, we will try to be on time. This is a special session from the Neuroanatomy Committee, World Federation Neuroanatomy Committee, in recognition of the great work of all of you as speakers, but in specific, Professor Edlos, who has the major contribution. We learn from him a lot, and Professor Rodolphe Falbush. Both they have major contribution worldwide and in their continent. Needless to say as well, Pablo Capabianca, his contribution to the endoscopic pituitary surgery has been tremendous, and we were all became young students to visit him and sometimes and learn from him. The other speakers, they have their major contribution, Nelson and Fred and Professor Abari, and I'd like to thank all of them for willingness to join us and teach the young generation how to perform a good pituitary management. Without further ado, that session will be moderated with my colleagues, Professor Miguel Reyes from Spain, who kindly accepted to be co-moderator. He has been always an invited guest to our webinar. And Professor Sanjeeva, I don't see him here. He is from Oxford. I hope he will join at some time.
No, I'm here, Imad.
Oh, here you are. So introduce yourself and say hi to everybody because they don't.
Hello, everybody. Nice to see everyone again.
Yeah.
Welcome.
Okay. So without further ado, I might ask Professor Falbush to give his presentation. Please, Rodolfo, you start, please.
So I start with my presentation on history of pituitary surgery. Everybody can hear me, please confirm and see me. It's okay?
Yes.
Good.
Yes.
Yes.
So thank you. This contains, of course, aspects, and forgive me if all not the important personalities who developed main contributions in this field will not be mentioned. That's not my intention. And of course, because of restricted time, I have to concentrate on the adenomas mainly. Starting with Victor Horsley at the end of the last century in 1989, you see his environment, of course, difficulties with analgesia, sterility, surgical devices, and mainly no imaging. Röntgen's discovery of the so-called X-rays were 3 years later, but not available at that time. To now, our brain suite, maybe we are over-equipped. If you see, of course, we don't need all this equipment, as you see there, with intraoperative MRI in the middle and microscope, navigation, and so on. However, a normal pituitary adenoma resection will be 1 hour. For special cases, we need a little more. History can be divided in three major phases, beginning around the century, then the second part with the development of microsurgical tumor removal, and the last part with improved surgical accuracy. The first part is combined with important names like Horsley, Krause, Schloffer, Cushing. The second one was Hardy's selective adenomectomy and imaging. The whole development was accompanied, especially in the second part, with the beginning of the 60s, by endocrinological approaches and classifications, and diagnosis and replacement therapy became possible. And in the third part, we had alternative endocrinological treatment available besides surgical improvements. I'm sorry, it doesn't work. I'm very sorry. I have difficulties with my presentation, as you can see. Oh my goodness, very sorry for that. I don't know why.
You can try to exit presentation mode, choose your slide, and go to presentation mode again.
No, it doesn't work. It doesn't work.
Can you press S?
No, it works. It works this way. Okay. Backwards. No, I mean, okay. The evolution of pituitary surgery was always a continuous competition. Transsphenoidal versus transcranial, depending on pre and intraoperative visualization. With the transsphenoidal approach, which environment, starting with a loop, later on the discussion microscope versus endoscope, or both together. Then transsphenoidal surgery versus endocrinological treatment and alternatives based on proliferation parameters, and of course on molecular biology. The evolution of pituitary surgery started in the beginning of the century with a domination, clear domination, 100% of the transcranial approach. Transsphenoidal approach rised and had its summit around the middle of the 30s, also pushed forward by Cushing, who at that time abandoned it because of poor vision. And then transcranial surgery rised again. And with the beginning of the introduction of the microscope, a new chance for the transsphenoidal approach, the yellow line, started, which was supported by MRI, later on by endoscopy, and especially with extensive transsphenoidal surgery. My special experience started in '69. I overlooked this time with my first pituitary operation. Transsphenoidal approaches, we have to divide between midline approaches, that is A1, 2, and 3, with extra axial approaches, which is mainly the transethmoidal approach. The first successful operation of a pituitary tumor via nasal approach was performed by Schloffer 115 years ago and published in Wiener Klinische Wochenschrift. Even 2.5 months later, he published the poor result. Who will publish today, 2.5 months later, a poor result, but he did it, sudden exitus. Of course, this very large adenoma, I think, had problems with incarceration in the suprasellar part. You see here the lateral rhinotomy performed by Schloffer, and we celebrated this event 100 years after, in 2007, in Vienna, in the Billroth House, and some of the contributors who I see here were also present at that time. Besides Schloffer's first publication, we had a second publication a little later by von Eiselsberg Wien, and I think the operative treatment of tumors of pituitary region was the first publication of craniopharyngiomas. And until 23, he had about 25 mortalities, which was respectful, has to be regarded in a respectful way for that time. You see the different approaches, including Schlofer, van Eiselsberg, Kocher improved. However, only until 15 years later, about 100 transsphenoidal operations were reported by Hirsch. Hirsch favored the submucous transsphenoidal approach, multi-step way, extensive, well-documented personal series. He emigrated from Vienna to Boston in 1938 and practiced there in the General Massachusetts Hospital until 1965. And I witnessed when Nick Servers had used his instruments for pituitary surgery much, much later. Oskar Hirsch defined the pituitary surgery as a borderline topic because he originally was an ENT doctor, and he took over the tradition, or this tradition continued in Austria by Burian, even in the Scandinavian countries till today. And even today, if you use endoscopy, many of our neurosurgical colleagues use also the endoscope. In his first period, he was happy to reach the tumor, then to lower the mortality. In the last period, he improved long-term results, especially started with a low mortality rate using antibiotics with 1.6% and 68% were in good health. Oskar Hirsch's submucous tunnel is still used till today by many neurosurgeons who started the operation in the nostril. And it is also used, was also used by Cushing, but he introduced the sublabial approach, and his mortality rate at the time was 5.6%. He refined this nasal approach. However, he studied also pathophysiology of pituitary disorders after resecting pituitaries in dogs, defined pituitary insufficiency and possible treatment at that time and so on. However, finally, he abandoned the transsphenoidal operation and changed over to cranios. You see here the different inferior transnasal approaches with Hirsch, Cushing, sublabial, and Carnavale. This is the transethmoidal approach introduced by Chiari, till performed today by a number of ENT doctors who have a skull-based approach to the area of the pituitary gland. And not forget the transpalatine approach, who can be, I personally used in dogs because the dogs have no sphenoid sinus and you have to go directly from there to the pituitary gland, but normally used from my point of view, but in tumors outside the pituitary gland, of course. Switching over to the frontobasal extradural approach used by Cushing and illustrated here. Then coming to the temporal approach used by Victor Horsley at the end of the century. Just before some years, Caton and Paul were supervised by Horsley, and maybe this was the first pituitary operation. Interestingly, in Queen Square, I've seen that Lindsay Simon still used or favored the transtemporal approach to reach the cellar area. Coming to Fedor Krause, who studied in Hamburg-Altona, Germany, and later on went to Berlin. And he performed, obviously, the first successful transfrontal operation. Having this inspiration by an 18-year-old male who had a gunshot. He was fallen in love, but not happily. And he reached this area via this approach and was fascinating, and that this operation is dangerous and serious. However, procedure is still needed under certain conditions, but it must be used only for tumors that cannot be reached on another approach, which means the primary supracellular tumor with a considerable diameter and intracellular neoplasm with a large supracellular extension reaching into the cranial cavity. Coming to Walter Dandy, who had a larger frontal temporal approach to the pituitary area. He also was experienced in transpalatinal operations in dogs. Finally, the last 20, 30 years were dominated by Yajagil and later by Sami, who offered us these approaches. In the beginning, I favored also the pteronal approach, and later on, since about 20 years, I'm on the frontolateral approach line, like Sami, with whom I'm working in the INI together. Coming to the second period, end of the 60s, which I really witnessed And there were two parallel developments. On one hand, the operative microscope was introduced, and it maybe enriched mainly the transsphenoidal approach, but also the transcranial one. And on the other hand, I was very happy with the endocrinological developments. The first hormonal analysis, think about Yalo with a RIA 69 and Friesen 77 prolactin. Then it was able to measure hormones, to diagnose exactly, and have also a basis for adequate replacement therapies. Transsphenoidal approach, after Cushing left and Hirsch continued, was also performed by James Hamburger, but mainly by Sir Norman Dodd. He learned Cushing's approach, installed light source at the speculum, and he was especially a teacher. Unfortunately, we have no real publications by him. So my really favorite star of that time is Gérard Guillot, who personally was present and gave a fantastic lecture on the symposium we had organized together with Klaus von Werder and Rottach Egan close to Munich. He continued to practice transsphenoidal surgery, utilized the semi-sitting position, used the loop, started endoscopy, an extra chapter, favored additional cobaltotherapy because he didn't trust in total removements and wanted to prevent recurrences by this. And he discovered as one of the first neurosurgeons at all that only half of his acromegalic patients had normalization of growth hormone postoperatively, and he was really surprised and went on with second operations in these cases. And especially, he instructed his co-workers and visitors from all over the world, like de Rome, Hardy, Bassot, Kerabol, Landolt, and. Jules Hardy, another hero for myself, because he favored the operative microscope. He changed from the loops, of course, also introduced fluoroscopic control, and he defined selective adenomectomy at a time when no endocrinologist could believe him because the hormones were not discovered and were not measurable, and one could not really confirm functional outcome. And he was attacked at that time. I really have high respect that he did overcome all that. We look here in this operating theater, you know that all, and especially what Ed always emphasizes, the straight middle line approach, as is shown here, and also in the picture up, to keep the midline to his patient. I personally stand on the other side of the patient, as many of the others like Engelbert, Knoss, and so on. So this is a selective adenomectomy, defined first on the anatomical basis and later by functional definition, and up to 90% of remission can be expected today if we perform this kind of resection. We come to the second part of the second period, when the imaging was improved by MRI, which gave us a lot of confidence in our procedures, and also in endocrinology, when ACTH microadenomas could be defined better in 50% positive in MRI in Cushing's disease. And there was more and more power of medical treatment, especially in prolactinomas and GHOmas, sometimes as a competition for surgeons, but in many places already at that time as a complementary treatment. This is the well-known situation, Harvey Cushing's case number 6, where he discovered the basophil adenoma, and Hardy's selective adenomectomy is understandable by that. And we published a series on more than 400 cases starting in the beginning of the 70s with that tumor resection. This is a typical case. We have a 3 millimeter adenoma resected, and the highly elevated cortisol levels dropped down to subnormal, suppressed to below 2 microgram per DL under all glucose, and then increased steadily in the normal range. Before recurrence in the upper normal range, we are no longer a positive, successful suppression by dexamethasone. Then after the recurrence operation, we had good results in the subnormal range here over 20 years. So we see till today recurrences in about 15%, and normalization had developed up to 70, 80%, in some cases even higher in the literature. At that time, till 2005, we had the majority of non-secreting adenomas because prolactinomas, the highest number of tumors, were also treated at the time by medical treatment. We see that 90% is treated only by transsphenoidal and the others by transcranial surgery. Some had to be resected on both ways to achieve a highest resection rate. The mortality was low, 2.5, 2.6%. Besides these adenomas, which are dominating in my series, which is meanwhile more than 5,000 cases, we had also a high number of craniopharyngiomas, meningiomas, cystic lesions, and others, which is not the content of my talk. Of course, we were able, with experience and microsurgical resection techniques, to remove such giant adenomas via transcranial approach. It's also possible via a frontolateral approach. Meanwhile, at that time, I used the terminal approach. And here you see complete resection of the tumor with preservation of the pituitary stalk and the pituitary gland, which in these large tumors is possible not only in microadenomas, but of course not always. Especially in these macroadenomas, I have to emphasize that, of course, in transsphenoidal operations, if possible, we have higher improvements and unchanged rates, but it's possible to have improvements even in transcranial operations. Coming to the two steps, surgery in short-term intervals in this giant adenoma, which was firm and didn't drop down totally. This was right, was left, and then coming via transcranial, have a complete resection, again with preservation of stalk and pituitary gland. Why was it so? Because this tumor sticked to the optic chiasm, as you can see here, and we, after a stepwise removal, the chiasm is free, and we also could preserve lots of the tiny arteries supplying the optic chiasm. And I favor also personal treatment if it is indicated in the patients like this one, who was more important to reduce the tumor mass here and then perform radiotherapy, which resulted in good control in shrinking of the tumor. We had improvement of vision, however, as a result of radiotherapy hypogonadism. Coming to the last part, improved surgical accuracy, navigation, endoscope, and microscope. And on the other hand, improvement of medical treatment, especially with the introduction of somatostatin analoga and GH receptor antagonists. Prolactinoma, very large like this, and with a major invasion of the cavernous sinus, maybe Knos 4, I think, disappeared practically completely with nearly normalization of prolactin levels under medical treatment. And in prolactinomas, medical treatment is dominant. It is nearly not possible or not effective enough in acromegaly, where surgery is totally dominating. However, in medical treatment in GHOMAs is coming, although in GHOMAs still the first treatment is surgery, which is highly effective in microadenomas with up to 90% remissions. Besides ultrasound, navigation, endoscopy, and intraoperative MRI played a major role. And endoscopy, of course, very important, opened many new fields, especially for non-adenomatous tissues in extended transsphenoidal approaches. And it favors the approaches for tuberculum, sedic-clavis, and cavernous sinus. Navigation in, of course, about the difference between Harvey Cushing's visualization and the navigation microscope today, mainly for encased arteries, second operations with no anatomical landmarks. Here in a case with narrow carotid arteries, about 5% of the population, where you can inject the structures of the carotid artery and the cellar floor into the eyepiece of the microscope and know always where you are, could resect the tumor, or in proximity to the carotid artery, which is maybe seen here. This is where we are always before the operation, and here after the operation, where we are very close to the carotid artery. Of course, endoscopy, which I perform mainly as assisted endoscopy, gives us a wonderful overview into the cavernous sinus. easy to find the midline between the protuberance of the carotid arteries on both sides, where we open it with a drill, mainly see the microadenoma, resected microadenomas with small curettes, more than 2 millimeters. And this is the end, only small incision in the vomer area with a small sphenoidectomy is necessary in the majority of the cases, not resection of all the mucosa. And of course, the difference with visualization is very clear. Microscope, endoscope. Here in cavernous sinus, much better. You have the impression of total removal. And if you have a displacement, the carotid wall can also be seen nicely after tumor resection. And I have to emphasize the high importance of Joe Cababianca, who is present, and Frank, whom we lost during the last time, unfortunately, in this field. On the other hand, there are a lot of publications who take care about endoscopic versus microscopic operations, and they don't see a major difference, also not in the outcome in micro and macroadenomas. But the story goes on, and I personally think either the microscope or the endoscope will survive in what we have today. We will have other devices for visualization. So we have to go on to improve the visualization of the tumors. Coming to the introduction of the intraoperative MRI, which was in 96 in Germany, when we have to start with low field, bring the table from one to the other place here. That was a little complicated here, operating at the table. And then the big advantage in 2002, introducing the 1.5 Tesla, and which is also in the brain suite in Hanover. And I experienced with more than 2,600 operations without any negative side effects. We have to turn around the patient here at the 5 Gauss line and bring in, as you see here, the patient into the gantry. And that took us about 20, 25 minutes. And you see that more than 150 that was 2014 was installed, 200 in construction. I think we have more than 200 now. At that time, the low field dominated, but now even we have more high field tumors systems, and I think that is also combined with high quality. However, they have to be cheaper. One example, large intrasupercellular tumor. Here we thought we have resected the main part, and this was the descending diaphragma, what we see here, but we continued surgery, removed the tumor totally. And you see the descended pituitary gland here, and that the cavernous sinus is completely free. Where are the remnants? Anteriorly in the descending folds, where we fear CSF leak if we are doing too much, or posteriorly, even tiny pieces, where we're too lazy to drill in the clivus, or going to cavernous sinus, where we feared bleedings. And
you have 2 minutes, Rodolphe.
How much?
2 minutes.
Okay. Then we have seen that we could really profit in 14 to 40% of the tumors. And of course, the increased resection here was reported to be higher in different ones. And people even working with endoscopes say that this is superior. History of cavernous sinus, the names are written here. We could cure focally invasive tumors up to 24%. And you see this also, that we have, as larger the tumor, as less normalization rates. We have an experience with 66%. In the later series, the last 100 runs, especially in micros, we improved to 15%. So I will skip this evolution of craniopharyngiomas, which is a big, big challenge. Here we have a complete removal with preservation of the pituitary stalk. Sparing the hypothalamus is a big topic. Finally, the history of pituitary surgery includes optical imaging, robotics. This is how we can today separate remnant adenomas from the gland by folate infrared receptor, which works unfortunately now in inactive adenomas, confocal reflected microscopy, gland adenoma, optical coherence, adenoma versus gland, this will develop. Also, the robotics may be. And I have to emphasize that the Pituitary Society, with definition of tumors, centers of excellence, co-working by a lot of neurosurgeons included here, played an important role. And within neurosurgery, interdisciplinary cooperations such as the International Society of Pituitary Surgeons with Ed Laws or ISECO, and also the committees. We just said the endocrine committee and now the anatomical one played an enormous influence. And this is my last slide, because I just mentioned Ed Laws and Nelson. It happened in Munich. This is a famous Munich humorist and comedian, Karl Valentin, who said, the future was in the past also better. And he lived in Munich and had reminded the first WFNS Congress in Munich in '81, when we discussed and you decided also with me and realized the EPS, who is chaired now by Oyezeku, very important development. And I hope continuous neurosurgery development and education will go on. Thank you for your attention.
Well, thank you very much, Rodolphe, for this very comprehensive review of the history of pituitary and surgery and the vast experience you have. I'm sure we restrict you with the time to cover the other subject. Craniopharyngiomas, I know it's a deep subject for you, but we are again covered by the time. Thank you very much. I'd like to invite, if we have one or two comments, short, please, or questions to Professor Falbush. Okay.
I would just say this was a wonderful, comprehensive.
Just 1 minute. Yeah.
View of where we are and how we got there.
Okay. Vladimir, you have some comment or question?
Yeah, I have very short remark. First, Rudolf, I must thank you again that you have taught me the end of the approach in 1985, long time ago, and that was one of my best visits. I only have one question to you. You know that we have 3 Tesla intra-op MR, and I have the feeling that we see much better the dura and all the structures within the cella than with 1.5 Tesla. What's your opinion on that?
Yeah. Can I answer? Yeah, I think the 3 Tesla has some advantages that
Sorry, Pablo, can you mute yourself?
Yeah, mute Imad.
I can answer. Do you see me? Do you hear me?
Yes.
Yeah.
So the 3 Tesla has some advantages as maybe nicer and more elegant sequences, is also quicker. But unfortunately, the resolution is not so much better intraoperatively than the 1.5. Of course, I will decide if I could to have a 3 Tesla. And maybe the dura, that means the supercapsule, can be visualized even a little bit nicer with the 3 Tesla in some cases, I agree. But at the moment, I don't see so much differences. But what I appreciated, and you are doing this also, use the T2 sequences. They are much, much better. And the Tuka also agree with that than the T1 sequences, which maybe are not so convincing from my opinion.
Yeah. T2 is the neurosurgical image.
Right. If there is no other comment, I'd like to go for the next speaker. Nelson, are you with us? Nelson Oyezeku? I think he called me. He is preparing himself.
Hi, Imad.
Hi, Nelson. Good to have you. Good morning to you.
Everybody. Good afternoon, everybody. Good evening, everybody.
Yeah. For the people they don't know, Professor Nelson, he is the incoming president of the World Federation, and he is a professor and the director of neuroendocrinology lab in Emory. I think he's on the merge to move somewhere else. I'm not going to say it. He can say it himself by March. So he will share his experience on pituitary surgery and the evolution for past and future.
Thank you, Imad, and congratulations to my dear friends and mentors, Professor Rudy Falbush and Professor Ed Laws, on this wonderful milestone on their first shrift I think it's a great honor for us to be here to see both of them who have been champions and mentors to all of us for many, many, many years and have led the field of pituitary surgery worldwide. So Ed, my dear friend and mentor, I honor you. Rudy, same thing, dear friend and mentor, I honor you too. So thank you, Imad. What I wanted to do was to discuss the evolution and revolution in pituitary surgery and medicine. So please let me share the screen here. First, I believe. Share the slide. Give me a moment, please. Go back. Share screen. Let's see the video. Okay. Very good. So, can you see the slides now?
Yes, go ahead, please.
Perfect. So evolution and revolution are both related concepts that both describe change, but differ fundamentally. Evolution tends to be gradual and usually continuous, somewhat incremental in its stepwise fashion, but its effects tend to be long-lasting. Revolution, on the other hand, is more of a sudden, extreme change in the way things happen. It may last very long or not, but the time spans for revolution are usually short compared with evolution. So I'll cover some of these ideas and discoveries as well as technologies that have played a role in pituitary medicine and surgery. So the transnasal approach to the skull base and intracranial structures was first devised by the ancient Egyptian morticians who wanted to exacerbate the cranial vault during mummification. The original technique was a sphenoidal approach, and the technique was abandoned for millennia only to be resuscitated in the Middle Ages. Endoscopic techniques date from the early 1800s, almost a century before Schloffer performed the first transsphenoidal surgery in 1907. Endoscopy was driven by the need to inspect hollow organs, and Philip Bozzini is credited with inventing the endoscope. Although it provided poor visualization for the surgeon and physician, it was a painful evaluation for the patient, but it did prove to be revolutionary. Max Nitzer, a German urologist, improved on the early endoscopes by magnifying and illuminating with an internal light. However, our knowledge of pituitary disease really dates from Pierre Marie's papers on acromegaly and Minkowski's findings in 1887 of a causal relationship between acromegaly and pituitary hypertrophy. Excuse me. The appreciation that the pituitary gland was essential to life was made in 1907 by Nicholas Polesko following experiments of hypophysectomy in dogs. Sir Victor Horsley of the UK is considered to be a pioneer of pituitary surgery and claimed to have performed the first pituitary operation in 1889. Horsley published his surgical experience with pituitary tumors in 10 cases, and he's credited as the first to successfully remove a pituitary tumor through the transcranial approach. David Giordano from Venice and Francesco Durante were important pioneers of endonasal surgery. Giordano proposed a transglabellar nasal approach to the pituitary based on cadaveric dissections. His approach was internationally recognized, and prominent surgeons such as Hermann Schloffer from Austria and Theodor Kocher of Switzerland, as well as Harvey Cushing, adopted his modified strategy. Durante, Giordano's contemporary, developed a transpalatine route to the gland. In parallel at the time, ENT surgeons were applying the endoscope to the nasal cavity. And in 1901, Alfred Hirschman from Berlin modified a cystoscope to inspect the maxillary spaces. In 1907, Schloffer described the transsphenoidal approach for resection of a pituitary tumor at the University of Innsbruck, and he postulated at the time that the tumor resulted in ophthalmological deficit, and therefore a reduction in tumor volume would prove relief, which in fact it did. His approach was guided by preoperative X-rays, shown here. The approach took 75 minutes without serious complications. His postulate proved true as the patient had complete resolution of both his headaches and improvements in his visual fields. His success ignited interest in transsphenoidal surgery. Harvey Cushing gave his celebrated lecture to the American Medical Association on the hypophysis cerebri in 1909, where he introduced the concept of hyper and hypopituitarism. In the early 1900s, pituitary surgery advanced quickly as surgeons in Europe and the United States developed variations of transnasal routes to the sella turcica. Theodor Kocher of Bern in Switzerland proposed a transsphenoidal approach by submucosal dissection of the nasal septum. Kocher's strategy addressed two major shortcomings of transsphenoidal surgery at the time. Firstly, the submucosal dissection of the septum reduced the risk of infection, whilst at the same time expanding visualization within the sella and had a better cosmetic outcome. In that same year, the ENT surgeon Oskar Hirsch of Vienna proposed an endonasal approach to the sella. In Chicago at the same time, in 1909, Halstead of Northwestern reported the first successful resection of a craniopharyngioma by an infranasal transsphenoidal approach as proposed by his colleague, Alan Knabel. In 1910, Halstead also described the sublabial approach to the sphenoid. Halstead's technique preserved the septum and did not require a facial incision, which of course resulted in a better cosmetic outcome. Also in 1910, Hirsch performed the first direct transethmoidal operation without reflection of the nose. The operation was performed in 5 stages over 5 weeks. Hirsch then evolved the first endonasal transeptal transsphenoidal procedure on June 4th, 1910. He also is credited with introducing the nasal speculum for the procedure. Coincidentally, on that same day, June 4th, 1910, Harvey Cushing of Boston also performed the first procedure combining the sublabial incision with submucosal resection of the septum. Hirsch and Cushing corresponded, and in 1911, Hirsch demonstrated his endonasal approach to Cushing. In 1938, Hirsch was forced to leave Vienna due to the political situation brewing in Europe at the time, and he relocated his practice to Boston. Between 1910 and 1925, Cushing treated 231 pituitary tumors by the sublabial route and was able to achieve a mortality of 5.6 in an era before antibiotics and hormone replacement therapy. Hirsch and Cushing made transsphenoidal surgery the preferred approach for pituitary tumors. In addition to his classical accounts of acromegaly, Cushing also published his findings of the polyglandular syndrome that would become known by his name, Cushing's disease. At the same time, reports of obstetric infarction by Simmons in 1914 and Sheehan in 1939 further illuminated the role of the pituitary and the clinical concept of hypopituitarism. Norman Dott was Cushing's Rockefeller Fellow at the Brigham from November 1923 to June 1924. Dott co-authored Cushing's experience and continued using the transsphenoidal route upon his return to Edinburgh. Furthermore, Dott designed a lighted nasal speculum that now address the problem of poor illumination in the deep surgical field. Around 1925, Cushing's faith in the transsphenoidal approach began to falter. And by 1927, he began using the transfrontal approach for pituitary tumors. And by 1929, he had completely abandoned the transnasal approach in favor of the transfrontal approach. Because of Cushing's outsized influence in neurosurgery, transsphenoidal surgery fell out of favor for nearly 35 years, and the fate of transsphenoidal surgery entered a dark era. A review of patients' records from Cushing's series reveals that the reason for his abandonment of the transsphenoidal route was primarily related to the limitations of this approach in providing effective resection of very large pituitary tumors. The symptomatic tumor recurrence rate after the procedure was substantial. Furthermore, given the preoperative uncertainty about the suprasellar extent of the pituitary tumor prior to modern imaging, the transfrontal route was able to assure Cushing that he had an adequate decompression of the optic chiasm. By 1927, Cushing's mastery of intracranial surgery was accompanied by the use of electrosurgical methods that enabled him to remove cellular lesions through the transfrontal route safely with timely and effective restoration of visual loss. Meanwhile, Hirsch continued to defend the transsphenoidal approach and continued to perform his endonasal procedures until he passed in 1965, as did Norman Dott in Edinburgh. Transsphenoidal surgery remained relatively dormant, awaiting the efforts and enthusiasm of Norman Dott, who bridged the gap between Cushing and Gerard Guillot, the surgeon who then revitalized transsphenoidal adenomectomy for the future generations of pituitary surgeons. Despite the lull in surgical advances, the next revolution in pituitary disease was medical, largely from the brilliant work of Herbert Evans and his colleagues, who isolated a number of pituitary hormones at the University of California at Berkeley. Most notable were the isolation of luteinizing hormone in 1940, ACTH in 1943, growth hormone in 1945, and FSH in 1949. The measurement of endocrine function was further revolutionized by the introduction of the technique of radioimmunoassay in the 60s. The revolution continued with Professor G.W. Harris, who literally created the new field of neuroendocrinology. Harris proved that substances in the portal vessels regulate pituitary hormone function, and also demonstrated that sectioning of the pituitary portal vessels and stalk caused only temporary loss of pituitary function unless regeneration was prevented. Hypothalamic hormonal research took off following the isolation of TRH in 1966, the isolation of GnRH in 1971, and then somatostatin in 1973, and then GHRH in 1982. Perhaps as a result of the medical advances, or maybe in spite of them, the surgeons arose from their slumber, and the renaissance of the transsphenoidal approach appeared due to several key figures: Norman Dott, Gerard Guillot, and Jules Hardy. Concurrently, the development of the rod lens magnifying system and advances in fiber optics were transforming endoscopy. In 1956, French neurosurgeon Guillot visited Dott in Edinburgh, and by that time, Norman Dott had performed 120 procedures with 0 mortality in his final 80 cases. Dott convinced Guillot of the efficacy and safety of the procedure, and Guillot purchased his instruments from Norman Dott and then went back to implement the transsphenoidal approach in Paris. In addition, he introduced intraoperative fluoroscopy, allowing for real-time visual confirmation of the depth and position of the surgical instruments. With Guillot's over 1,000 cases showed convincingly that the transsphenoidal approach for pituitary tumors was superior than the transcranial approach. Guillot also demonstrated lower morbidity and improved visual outcome. Furthermore, he used the transsphenoidal approach for other tumors such as, excuse me, please, such as craniopharyngiomas and chordomas. In 1961, Guillot was the first to report the use of an endoscope for resection of cellular and supracellular lesions via the sublabial transsphenoidal approach. Unfortunately, Guillot was still using endoscopes based on Nitz's system and therefore abandoned endoscopic pituitary surgery due to inadequate visualization. But he continued to use it occasionally following resection to examine for residual. Hardy studied under Guillot and returned to Montreal in 1962, where he introduced the surgical microscope in 1965. This was a great technological revolution in transsphenoidal surgery. The indications for transsphenoidal surgery expanded further to include functional adenomas, but visualization was still limited to a straight and narrow view of the cellar. To address this issue, neurosurgeons would use angled mirrors to view outside the line of sight. The superior illumination and binocular magnification enabled Hardy to perform the selective adenomectomy of pituitary microadenomas, and Hardy coined the term microadenoma in 1968. The next major breakthrough was evolving in tandem with the new development of a new lens system. In 1960, Hopkins patented a system which improved light transmission and image quality within a smaller diameter. And this also provided a wider field of view. And together with Karl Storz, a businessman in Germany, they developed and licensed the fiber optic external cold light transmission system. And in 1965, they began producing the Storz-Hopkins endoscopes. Endoscopy made many other improvements, including the CCD camera, and clinicians were then able to document their operative findings using the endoscope. Imaging brought the next revolution, with first CT and then MRI providing surgeons with a degree of diagnostic insight as never before. Operative planning and the execution of surgery improved, as did the patient outcomes. The application of molecular biology to neuroendocrinology became the next step in the evolution, as the structure of the genes encoding for various hormones were elucidated in the early 1980s. Pathological diagnosis also evolved, with immunohistochemistry, electron microscopy also providing further insights into the cellular biology of pituitary adenomas. Diagnostic testing also evolved further with dynamic assays and, of course, the inferior petrosal sinus procedure. The development of molecular techniques illuminated the pathogenesis of pituitary adenomas, proving first that pituitary adenomas were monoclonal in origin in 1990, and then that genetic mutations were responsible for the selective expression of single cell clones. For example, the discovery of the mutation in the G-alpha S protein subunit in growth hormone tumors responsible for acromegaly due to the constitutive activity of cyclic AMP, increased growth hormone production, and then more recently, the USP8 mutation in Cushing's disease, showing that the mutation in the binding domain of USP8 leads to USP8 cleavage, excessive ubiquination, deubiquination, increased cycling of EGFR to the surface, sustaining EGFR activity, resulting in enhanced transcription of ACTH, production of cortisol, and cellular proliferation. The molecular biological revolution has brought with it a medical dividend, as first, the dopamine agonist bromocriptine, followed by cabergoline for hyperprolactinomas, hyperprolactinemia and prolactinomas. Secondly, octreotide and other somatostatin analogs for GH hypersecretion and acromegaly. Soon followed also by octreotide and pegvisomant, the growth hormone receptor blocker for GH hypersecretion. Excuse me. These have modified our surgical indications, have raised the bar for surgical outcomes and interventions, and have also expanded the therapeutic repertoire for our patients and physicians. The application of the endoscope to diseases of the paranasal sinuses was the catalyst for reintroducing the endoscopic endonasal approach. In 1978, Wolfgang Draff reported his clinical experience on the therapeutic endoscopy of the paranasal sinuses. And along with other ENT surgeons, including Heinz Schamberger and the American Dave Kennedy of Philadelphia, together pioneered the functional endoscopic sinus surgery procedures for the maxillary, sphenoid, and frontal sinuses, and coined the term functional endoscopic sinus surgery. This reintroduction of the endoscope underlined the limits of the microscope and proposed the new case for endoscopy, first bringing light close to the deep field and being allowing to observe and see asymmetric tumors and lateral extensions. Excuse me. Almost concurrently, in the 1970s, two separate groups used the endoscope as an adjunct to the microscope for tumors with extracellular extension. In 1977, Apazzo and his colleagues from USC reported that the combination of techniques allowed the visualization of anatomical landmarks and provided for better tumor resection. Busch and Haus in Germany also published a similar technique in 1978. The joint efforts of both the neurological and ENT surgeons led to the emergence of what was then known as the, quote, pure endoscopic transsphenoidal technique in the early 1990s, where the endoscope was used as the only visualization tool. Roger Jankowski in France reported the first use of this, quote, pure endoscopic sublabial technique for cellular lesions in 1992. And in 1995, Sethi and Pillay at the Singapore General Hospital described their pure endoscopic endonasal transsphenoidal approach for pituitary adenomas. A couple of years later, Joe and Carrao in Pittsburgh used the endonasal uninostril technique without a nasal speculum. The techniques and indications for endoscopic transsphenoidal surgery have continued to expand with the introduction of other technical adjuncts such as neuronavigation, microvascular Doppler, and miscellaneous other instruments. In 2003, Giorgio Frank and Ernesto Pasquini developed the transethmoidal, transpterygoid, transsphenoidal endoscopic approach for cavernous sinus lesions and tumors lateral to the carotid artery. And then the transtuberculum, transplanum approaches for anterior skull-based lesions, such as tuberculum cellar meningiomas, olfactory groove meningiomas, and craniopharyngiomas deep inside the brain. The concepts and applications of endoscopic transsphenoidal surgery have continued to expand. This is a short video of an expanded transsphenoidal, transtuberculum, transplanum operation for resection of a craniopharyngioma. This is the tumor underneath the chiasm extending to the third ventricle, as you saw in the MRI. The dissection is proceeding to elevate the chiasm and dissect the tumor away from the undersurface of the third ventricle. Gentle debulking of the tumor from below to allow the suprasellar and the supraventricular portions to descend, and then freeing up that tumor. This would be difficult to do without an endoscopic approach that is shown here. Then the tumor being delivered, and even large tumors that extend deep inside that might be candidates for transcallosal approaches can be removed successfully with expanded endoscopic transnasal approaches. With the new endoscopic techniques have arisen a new set of challenges and limitations. Notably, the loss of depth perception with standard endoscopes, the collision of the endoscope with surgical instruments, which can result in restricted mobility and bimanual techniques. These limitations are being addressed with the development of newer endoscopes, such as 3D endoscopes, shown here, malleable endoscopes, and further instrumentation refinements to produce better and more effective instruments for surgery. And then finally, I think it's important to understand that life doesn't get better by chance, it gets better by change. So evolution and revolution have been outstanding drivers of our successes in pituitary medicine and surgery over millennia, dating all the way back to the Egyptians and the morticians exacerbating the skull, to today's sophisticated endoscopic, expanded transnasal approaches that have increased the ability of surgeons to do the work we do. So thank you very much. And I, again, want to pay my respects, my very deep respects, and to both Rudy Falbush and Ed Laws for another outstanding milestone in their wonderful careers, and thank them for all the things that they've taught us over the years and their great friendship over the years to me personally. And I yield the floor, Dr. Kanan. Thank you so much.
Thank you, Nelson, for this wonderful presentation, combining all the aspects of the evolution together and give an inspiration for the future development. We'll can give 1 or 2 minutes for comments or some questions.
Yes.
Rudy.
May I ask you, because you have contributed also a lot in molecular biology, how far would you recommend a young neurosurgeon who wants to go into pituitary surgery to deal also with that? Because I think some of us had a molecular biological lab in neurosurgery. Is it today even sensible, because it's so complex, that a neurosurgeon will go on dealing with this personally in a lab?
Yes, I think there's continues to be a role for us to collaborate and interact with our colleagues in molecular biology, molecular neuropathology, and of course, medical neuro-oncology, because I think the advances can only come if we are involved and we are part of it. I think we're a very integral part of patient care. We obviously operate on these tumors and we retrieve these tumors. And as you know, my dear friend Michael, your protege, was at the helm of the investigations in the USP8 mutation story with Cushing's, and the neurosurgeons also in Shanghai were part of that whole investigation. So I think it's very important that we keep our fingers in the pie and we collaborate, even if we don't do the experiments ourselves, but we are part of that evolution and revolution story. And we have a lot of bright minds in neurosurgery, a lot of smart people that can help advance the field in collaboration with the molecular biologists and neuroendocrinologists.
Thank you.
Ahmed, may I have a question?
Yes, yeah, go ahead, please.
Thank you, Ahmed. Thank you, Nelson, for this really a wonderful overview of evolution and the evolution of the pituitary adenoma. I would say pituitary disease, because you are speaking not only about surgery but about also medicines and many. So my question: how about simulation in your talk? There is a place, there is revolution simulation for a learning curve or not, especially in a transnasal endonasal operation, endonasal endoscopic approach.
Yes, yes, Nadia, thank you so much. I think there's a great role for simulation, for sure. Technology today has brought in things like virtual reality, 3D animation, and augmented reality into the classic teachings in the cadaver lab. And one of the shout outs I want to give is I want to mention the work of Gabi Zada. Gabi is at USC, and he has, for example, put together this wonderful simulation of carotid artery injury during pituitary and transnasal surgery. And the student, the resident, fellow, attending surgeon can operate and then have that carotid artery injury simulated over and over again. So you practice getting control of that surgical emergency, for example. And of course, you can also use simulation in other areas of the surgical procedure. But I mentioned that as one of the good examples, the classic examples of the role of simulation in transnasal pituitary surgery. Yeah.
Thank you. Thank you.
Thank you, Nelson. Well, I hope that the analogy of revolution with the political revolution does not match the same things, because revolution in politics can be catastrophic, or you might have the result delayed. And I think here we are having the result almost immediate. The revolution in the evolution of technology, we are getting the good results, and we are progressing on this one. Is there any other question or comment, please? If not, well, thank you, Nelson, for having the time to share us. I know you have a busy schedule. I'd like to invite the next speaker, who does not need an introduction. He is, I think, the godfather of pituitary surgery in our contemporary time. And he is the mentor of the mentors, Professor Ed Laws. Professor Ed Laws, he's a professor at Brigham Women Harvard Group, and he is the director of neuroendocrine services in that hospital. I have followed Professor Ed Laws for many years, from the time he was doing the epilepsy surgery at Harvard, and his movement to Charlottesville, Virginia, where I was privileged to see the two legends working hand in hand together, a neurosurgeon and a radio surgeon, which Professor Ladislav Steiner, God bless his soul. And amazing when you see these guys discussing the cases together, how they come with all the scientific background and try to reach to each other to get the best for their patients. Needless to say that Dr. Ed Laws, he's a legend, but he's young at heart. He embraced all the new technology without hesitancy. When I remember when the endoscope was on the first stage of introduction in the medical practice, he was the avant-garde to welcome this one and support it, and support the trainees and the young generation to go into that field and improve their status. Professor Ed Laws, the podium is yours, and please share your experience with us. More than 6,000+ cases of transfemoral surgery. Professor Laws.
Thank you very much, Dr. Kanan, and thank you for the historical reviews we have just heard. They are absolutely amazing, and it's amazing to see how we have moved so far in such a period of time. And I've been enjoying every minute of it. From the first case I had in 1967 as a resident, stimulated by visits from Dr. Guillot, and the lectures of Dr. Hardy when we started the first of these 6,000 transsphenoidal operations. Now I need to advance my slides, and I'm not sure how to do that. Here we go. Yes. So staying out of trouble seems to be one of the most important things these days for those of us who are still trying to pioneer the transsphenoidal approach to the skull base and all of its problems. So most important, do not stray from the midline, because you can have a carotid or a cranial nerve injury. And keep your orientation, superior, inferior, as well as lateral, because of transgressing the cribriform plate or even the clivus. Dealing with bleeding and its control in a very confined area, using the endoscope and other instruments that are never perfect for cauterization, and dealing with the spinal fluid leak and its control. And finally, later on, nasal and sinus problems. Other things that we deal with are hormonal issues, and particularly need to follow thyroid and calcium in some of our patients. We deal with diabetes insipidus, with the syndrome of inappropriate ADH secretion, and with hyponatremia. And all of these things can cause a wonderful operation to be a quasi-failure. We see electrolyte imbalances, and we also see DVTs, and their prevention is an important part of our overall management of these challenging patients. Always remember that the endocrinologist is your friend and not the enemy. You recognize Georgi Murasan in the center, the acromegalic from Romania who came to the States and played basketball. And I operated on him, not only on his pituitary tumor, but on his lumbar spine, because he had facet hypertrophy causing an S1 radiculopathy and was about to lose his basketball pension. And so we removed his facets, and he regained his prowess as a basketball athlete. And the woman you see there is Mary Lee Vance, with an endocrinologist I worked with for 15 years. And I learned so much from her and her colleagues, and you must use them for your benefit. Now, remember that progressive visual loss is a real emergency, and it requires surgery. And this is a prolactin adenoma that caused, look at this vicious visual field deficit with the optic nerve and visual field compromise that was completely reversed when this tumor was removed. One thing before we go to surgery is that we have to measure their pituitary hormones, and that was just mentioned recently, how important that is to what we do. So if patients are hypothyroid, they may need thyroid medicine. And if you give thyroid medicine to a patient who is impaired in the cortisol axis, you may precipitate an Addisonian crisis. So always give her hypothyroid carefully, slowly, and don't provoke a catastrophe. And also measure calcium, just to be on the safe side. We learned that packing the oropharynx and the nostrils postoperatively no longer is necessary. The precision of our surgery now completely eliminates these issues, and we don't miss them at all. So we learned also that a Foley catheter is not necessary. As Professor Falbush mentioned, our operations don't take more than 2 or 3 hours. And so we don't require a catheter in all patients. And so I don't use them if we don't have to. And we don't use intensive care unit if we don't require that in specific cases that may have vascular risks. So we've gotten rid of some of the things that really were traditional, but are no longer very helpful. We do not use routine spinal drainage, either intraoperatively or postoperatively. We don't believe that it is desirable or necessary in many patients, and it's especially not desirable in elderly patients who don't respond well to depletion of their CSF. So instead of putting in a catheter and monitoring the patient for weeks and clamping the catheter and trying to remove it and having it leak again, we simply take the patients back. Now, we mentioned the positioning of the patient. I think this is one of the things I teach most vigorously to our residents and our students. We position the patient so that the midline of the patient's head is parallel to ambient space, the midline of the room. We also flex the head so that the dorsum of the nose is parallel to the floor of the room. These are ergonomic issues that really make a difference in care and in avoidance of complications. And this is the arrangement of the surgeons when we do either microscopic or endoscopic surgery with the surgeon and one assistant. And we can manipulate the thorax elevation by moving the entire table and thereby decrease venous pressure if we want to go into the cavernous sinus or have excessive venous bleeding in the exposure of a tumor. Now, anatomy is always important. It is for every kind of skull-based surgery, and you need to understand and identify the landmarks that are anatomic and that keep you out of trouble. Most important is the vomer, which is a midline marker in almost every patient, the rostrum of the sphenoid, which allows you to enter the sphenoid sinus carefully without causing a spinal fluid leak or impingement on the carotids laterally. So it's very important to know the anatomy and to respect it with the surgery and do it every time and correlate what you see with what you have on your imaging studies, mainly the high resolution MRI or CT studies. This is from Professor Capobianco, who introduced me to the endoscope and made me certain that it was an advance in our care of these patients with pituitary problems. And here we see landmarks that we could not see with the operating microscope previously. Here's the sellar floor. Here are the carotid protuberances. Here's the optico-carotid recess, the optic nerve here. Here's the planum sphenoidale with the floor of the frontal fossa, and here's the clivus. So we can see all of these anatomic structures in exquisite detail and thereby avoid many of the complications that were such a problem when we began doing these operations. So I use imaging control liberally. I do it mainly so the residents and the students can see where the instruments are located and manipulate them themselves. We can check the angle of approach, the trajectory, the floor of the sella, the junction of the sella with the anterior fossa and the clivus. Again, these safeguard the patient and are important adjuncts to our exposure. Now, sometimes the imaging studies give us a feeling this might be a vascular problem. And so if an aneurysm is expected, and I've seen two of these behind the dura, we need to interrogate the dura with the microvascular Doppler, which our colleague Dan Kelly introduced. And if the Doppler sounds like a vascular lesion, beware. And then we will occasionally, if we think there may be an aneurysm or even a cyst, we sometimes use a fine needle to interrogate the dural contents. And I want everyone to remember that the dura has two layers of dura, just like every other part of the head. And between the two layers is a vascular chamber. And so you must get through both layers and make sure that the venous bleeding is controlled that you produce by doing that initial incision. Now, if the sella is enlarged, the trajectory of approach can be manipulated to take out even very large tumors. And so to do this carefully and in accordance with the image guidance and with what you see on your imaging studies, one can take out rather large tumors safely as the diaphragm comes down. Now, here's the typical opening that we recommend, primarily for microadenomas, but for all others. We open the sella from the dural margins, the cavernous sinus on one side and the other. And we take off the floor of the cella in most cases, and we expose the tuberculum cellae in most cases so that we know exactly where these anatomic landmarks are located. We know we might get a CSF leak if we go too far in this direction. We know if we might get bleeding if we go too far in this direction. So this is the prelude to the entry. Now within the cella, one of the important things is to preserve the posterior pituitary function. The posterior pituitary has a unique position and a unique characteristic. For me, it looks like ricotta cheese. It's very fragmentary, and it's best not to remove it. But even more important is not to damage the axons of the pituitary stalk. These are the axons of the neurons in the hypothalamus, in the paraventricular and supraoptic nuclei. If you damage the axon, you get karyorhexis, and the tumor bodies may die. And that is when you get permanent diabetes insipidus. So don't crush these axons, don't damage them, don't pull on them. And if you have to section them, do it sharply with a quick knife cut, hoping not to produce damage that will retrograde interact with the body of the neuron and kill it. Now, if you don't have a spinal fluid leak, if you don't have a lumbar needle and you want to push the tumor down, if it's a soft tumor, instead of putting in a needle and injecting saline or air, I learned from Ivan Chirek that bilateral jugular compression can produce enough intracranial hypertension to push a tumor down. So without the use of a lumbar catheter, if you simply send someone under the table to compress the jugular veins bilaterally, you can deliver a rather large tumor sometimes. I was learned to obliterate dead space when necessary, and we use fat grafts, sometimes with a few cotton fibers in them, and then reconstruct the floor of the cella. And if there's no cartilage or bone, we can use an absorbable plate. So we do reconstruct the cella in many cases, not all of them, but particularly in those when there has been an intraoperative spinal fluid leak. Now in acromegaly, we know this is Cushing's first patient, by the way, when he was young and when he developed full-blown acromegaly, a farmer from North Dakota. In acromegaly, the bone is thicker, the blood vessels are larger, and the carotids are tortuous. They have dolichoectatic features. They can be calcified. They can have aneurysms. So you must be very careful. The distances between the carotids may be very small, and the distances for your tumor may be greater, and the instruments for the instruments may be longer in patients with acromegaly. More important is the anesthetic aspects of these patients, most of whom have obstructive sleep apnea from the acromegalic influence of the tongue and the oropharyngeal features. So our anesthesiologists often use awake intubation, endoscopic intubation, and it's very important to maintain a good airway in these patients. And another important thing about acromegalics is that they often look as if they have diabetes insipidus right after surgery because they have excessive urination. This, in most cases, is simply mobilization of interstitial fluid that is retained because of the excess growth hormone. And so if you give the patient a day or two, you may find that it is not diabetes insipidus. It is just a very good response to lowering growth hormone. Now with prolactinomas, we always discuss with the patient that we have dopamine agonist medications that can lower the prolactin in most cases. If that works, if the patients have a good response to medical therapy, they think you as a surgeon are a hero. And if they have a poor response, or more commonly now, side effects that are very unpleasant from the dopamine agonists, they'll think you're a hero and be happy to have you take out the pituitary tumor. So this is actually something that's changing in endoscopic surgery now, in that we're operating in as an initial treatment in many patients with small prolactinomas, and we're having a very good result. In our case, 94% remission. Now, Cushing's has, I think we will all agree, is the most difficult and worrisome entity that we trust. This disease is really awful, and it has so many different manifestations. And there are so many patients who have some of the features, but not all of them, and may not really have Cushing's disease. So please always consult with your endocrine colleagues and make sure that the diagnosis of Cushing's disease is secure before you operate on these patients. Petrosal sinus sampling was mentioned. It is helpful, but it may be misleading. Remember that it does not make the diagnosis of Cushing's disease. First, you make that diagnosis, then you can do the petrosal sinus sampling in order to have some indication of where the tumor might be located from one side to the other within the sella. It's something we use infrequently now, provided that all the other diagnostic features are correct. Patients with Cushing's do not need preoperative or intraoperative steroids. If you give them, then you can't tell for days whether the patient has entered remission. So we give them no cortisol and measure the cortisone in the morning every day for 3 or 4 days in the hopes that it will be very low as a result of removing the corticotrope tumor. If the Cushing's tumor right after surgery has a thorough removal and does not what we call crash, that is, develop symptoms that are very much like the flu of fatigue and headache and just malaise, if they don't have those features at least for a day or two, they probably won't go into remission. So we like to see that. We monitor them carefully, and we've not had any difficulty with them getting in trouble from adrenal insufficiency. Now, we learned from Rudolf Albusch that these patients with Cushing's disease have hypercoagulability, and the complications in patients with Cushing's are much higher for deep venous thrombosis than in other patients. In my career, we've had one case who died, and she had a deep venous thrombosis and a pulmonary embolus. We've also been very careful with sodium in those patients. Now, this is a grossly invasive pituitary macroadenoma, and we studied over 400 patients looking at the dura of these patients microscopically. And we discovered that almost 80% of patients with a tumor like this will have invasion of the dura. In my mind, that means that we always leave some of this invaded dura behind, and therefore recurrences are frequent in those patients who have partial removals of macroadenomas. And in those cases, Gamma knife or other forms of focused radiosurgery are helpful in preventing recurrences. Remember that a Rathke's cleft cyst, like this one, when you open it, looks like an abscess in some cases. It may look exactly like purulence or pus. That is typical of ordinary Rathke cleft cysts, and several of these have been reported as, quote, silent, unquote, sterile abscesses in the sella. They're not. They are Rathke cysts and must be treated in the same manner as other typical Rathke cysts. If there's no bone or cartilage for reconstructing the sellar floor, and you need to because of a spinal fluid leak or to prevent further complications, sometimes I use a little plastic piece of macropore. We no longer use the tantalum mesh, but it's also another option for closure of the bony defect in the sella. We discovered that in postoperative management, immediate postoperative management, we no longer do immediate MRI or CT scanning. The most important thing is a visual examination of the patient. they're the best guide to any significant postoperative problem. And so we've not relied on a lot of postoperative imaging studies in the immediate postoperative state. Now, what we do in the immediate postoperative state is take the patient back to the surgery if there is a postoperative spinal fluid leak. Again, rather than use lumbar drain or other measures in order to stop a brisk spinal fluid leak, we simply take the patient back to surgery. We often do it quickly with a microscope because everything is exposed, and we just reconstruct the floor of the sella. And that has been very effective in stopping the rare CSF leak in our practice. Now, I talked about electrolytes and their management postoperatively, and the most important one is delayed hyponatremia, which can occur in as many as 10% of patients. And we have tried to avoid this completely because, as you know, rapid repletion of saline and salt can produce a very difficult problem, which is central pontine myelinolysis, or sometimes even extrapontine myelinolysis, where the brain gets demyelinated and can be quite fatal. So in every case now that might be prone to develop a postoperative hyponatremia, we put them on a fluid restriction for 5 to 6 days after surgery. And that has been basically 100% effective in avoiding postoperative hyponatremia. This is a picture of central pontine myelinolysis. One Cushing's patient went to a rural hospital, was corrected in 30 minutes, I'm sorry, in less than 30 minutes, and developed this awful disease, which was fatal. Remember, some hypopit patients may not absorb oral steroids, so always give it parenterally if you're concerned about that. You know that they receive their steroids if you give it intravenously or subcutaneously. And postoperatively, when patients call and say they're unwell, it's almost always because of a cortisol deficiency or sodium disturbances. So in the emergency room, tell them to obtain a serum cortisol and a serum sodium, and that usually gives you the answer to the problem. We don't do post-op MRIs until 3 months after surgery. That's how long it takes for the surgical injury to repair itself. And we've stuck with that, and it's been very helpful to do a 3-month post-op scan. The other thing you have to have is a friendly ENT colleague, otorhinolaryngologist, who can help you with septal perforations, as you see here, sinus disease, postoperative epistaxis, or dealing with more complex anatomy. I've never had to take but once a turbinate process, and that's because I've had good help with my ENT colleagues. We do use radiosurgery after failed transsphenoidal surgery or recurrences. It's been highly effective in acromegaly and in prolactinomas, and it's been quite safe except for the complication of hypopituitarism that occurs in about 30 to 40% of our patients. Compulsive follow-up is necessary because these tumors recur. You all know that. So we can see it at 10 years. So we see them regularly. We measure their hormones and we do imaging if it's necessary because of their symptoms. You must recognize, this is my last slide now, of commonly recurrent invasive tumor subtypes. These must be monitored even more carefully. The silent ACTH tumor, the acidophil stem cell tumor, the plurihormonal tumor from different stem cell lineages, and the ACTH tumors in Nelson syndrome. These are bad actors and need to be followed and treated aggressively. And this is where Dr. Cushing went in 1912 to begin his series of transsphenoidal surgery for pituitary disease. We worked there in this office, which now was taken over by the administration, and we have a nice new building. But this is where much of it started, and it's been a pleasure to work there, and it's a pleasure to have been with all of these friends and colleagues who are at this wonderful meeting. Thank you so very much. Bye.
Thank you very much, Professor Lowe's, on that vast experience you have gathered and taught us all this information. I still use the needle whenever it's needed to make sure I'm not in the vessels on the cavernous sites or an aneurysm. I might lead one question. What is your take about functional pituitary adenoma that invade the medial wall of the cavernous sinus? Do you recommend to go after it? Because I've seen several presentations from the previous committee webinar on the neuroendoscopy. The people with the endoscopy, they take some, but there's still a good percentage left, and they end giving the patient gamma knife, but added the morbidity that I feel is underreported, especially when it comes to the cranial nerve and the vascular injury. Please tell us from your experience, how many times you do that?
Well, it's a difficult issue. I think we have all regained a lot of knowledge about the cavernous sinus, about its anatomy, and about the mechanisms of tumor invading the cavernous sinus through a puncture hole or actually invading the dural leaves of the cavernous sinus. Some people recommend, as you saw, resecting the medial wall of the cavernous sinus. For me, I know from the studies we've done before that we leave tumor behind no matter how careful we are, no matter how meticulous you are, you're still going to leave, and I said this to Vinko Dolenk for many years, you still are going to leave active tumor cells behind. So I think you can protect the carotid artery by decompressing the cavernous sinus. I think you can do the removal of easily accessible tumor with careful technique and good visualization. But how often we cure them, I think, is still a real problem. And to take any chances of damaging the carotid artery or the cranial nerves, I think, is not in the best interest of the patients.
Thank you. Any comment or question? Yeah, unmute yourself, Professor Najia.
Professor Edward, thank you so much for this amazing presentation and amazing experience, and I'm very great honor to be today with you in this panel. And my question, because I understand that you move to the endoscopy. We tell us with the Pablo, I don't know in how many years, but my question is, when you move from microsurgery to endoscopic, as master, as expert, as you, was it difficult, frustration in beginning or not? Because I know when we are more younger, it's we continue even if it's difficult. But when we are used to perform the same technique for many years, it's not. I think it's not easy. What's your opinion, please, Professor?
I think your points are very well taken. It does take experience. It takes a methodological approach to the issue. So the approaches are, first of all, to remove the cellular contents away from the mesial wall of the cavernous sinus to visualize it. As you know, the cavernous sinus is not just one big hole. It has many leaves of dura within it. And some of those leaves of dura cover the cranial nerves. They may cover the carotid artery. They may have separate areas themselves of bleeding. So you must first view the mesial wall of the cavernous sinus. The other issue is it possible safely to remove the bone over the carotid canal? If you can do that, even tumors that go all the way down the cavernous sinus, you can find them and selectively remove them from the carotid. Most of the time, the carotid adventitia is not invaded by these tumors. It can be. I've seen that, but it's very, very rare. So you can carefully manipulate tumor away from the carotid artery. You can carefully remove it from over the leaves of the cavernous sinus that protect the cranial nerves. And that's what I do. And you have the benefit of an angled endoscope so that you can actually see the perimeter of the tumor more readily than we could before with the direct view of the microscope.
Thank you so much.
Any other questions? If no question, comment, I will transfer the moderation to my brother and close friend, Professor Miguel Reyes, to conduct the moderation for and present the next speakers. Miguel?
Thank you very much, Professor Canan. First of all, I'd like to congratulate you because of, this meeting gathering such a constellation of pituitary stars, not stark, but stars. And it is for me a real honor and a real pleasure just to ask Professor Capabianca to start his presentation. I think Paolo Capabianca doesn't need any presentation. He has been leading, and he's leading one of the neuralgic centers all over the world in regard to pituitary surgery and endoscopic pituitary surgery. And we are very much looking forward to hear, Paolo, your presentation on endoscopy, transsphenoidal endoscopic approach for the management of pituitary tumors.
Thank you, Miguel. You have been very, very kind to me. And I wish to thank Dr. Canan for his great job he has done. But I shouldn't reply to the question that Naja had in respect to to Dr. Laws about his transition from microscopic pituitary surgery to endoscopic pituitary surgery. But I need to thank Dr. Laws for his inspiration and guide, but that's not all. I have to tell you what some of you may not know, that he's not a common human, but he's a sort of chimeric person, because he's at the same time very, very young. So he's able to move from a position to another with the elasticity of a 20-year-old person, and with the privilege of a huge experience, which is not common to most of the people around the world. So I've seen many people, included me, having troubles from moving to the microscope, to the endoscope. Troubles that young people usually don't have. He has not presented this situation because he's a chimeric man. So that's the secret he didn't want to tell us, but I have to tell all of you. And my presentation starts, I'm moving. Okay, you know that I always try to show that I come from Naples with its volcano. So we have an innate condition of trying to be on the history and to move forward. Our university was founded almost 8 centuries ago from a German emperor, which gives the sense of our strength, even though in Naples we look like living quietly. And we have seen also in the former presentation that there has been an evolution from the old Egyptians to what we are doing today. And endoscopic neurosurgery represents in some way this evolution in terms of technological advances. But we always need to remember that there is no difference between coming from below and from above if you have a proper recognition of the anatomy, which has to be studied with intensity because it's the real basement of the whole building. This is the Aula of Morgagni in Padua. It's an old anatomic theater. We are indebted to Manfred Schabisch in Bayern, where we received one of the most important for us lessons of anatomy. And endoscopy and anatomic dissection is very, very important. Every time you perform a dissection, you learn something about the work you are going to do on the living patient. And also anatomy evolves because the anatomy of the subject is there, but the way you learn this lesson with using computer-based models, with studying the working area where you are going to perform your operation, where when you understand the possibility of doing something where you see something, it's something we have studied in these years. We have had the need to use different instruments than before, with endoscopes that have been evolving. We had not a good relationship with the 3D endoscope. In our experience, has not been successful at all. While the 4K resolution of some new endoscopes has been very effective. And we needed also to, together with other colleagues, to develop instruments to work where we could see, to reach the point allowed by the working angle of the approach, and to work properly on the target. One of our friends that has been already quoted, Dan Kelly, Dr. Laws, always uses the microdoppler probe because we know that the carotid both are on the lateral aspects of the approach. So it's important to check the position of the carotid arteries. And also other instruments, the bipolar forceps are very useful. So all of us have tried to do better. And the surgical technique is important, but Dr. Laws has told us that what's important is the method we use to approach what we are doing. And so I think that besides who has been the first, the second, the third, it's not important, but Dr. Carrao has been crucial in the development of this approach through the endoscope, because he was a very good expert of the anatomy. And so first worked with this Dr. Joe, then with Dr. Cassan, but has been crucial. And these are the Italian friends. And for me, Dr. De Divizis was the teacher with whom we have worked together to perform what we have divided in 3 steps: nasal, sphenoidal, and cellular steps. In an anatomy that we didn't knew exactly, and now we always try to identify most landmarks, surgical landmarks along the approach. First, we lateralize the middle turbinate, then we remove a posterior part of the nasal septum, and we see here already, quite often, we see the cellular floor, but we have to be able to work properly on the target. And this is the posterior aspect of the sphenoid. You see the cellular floor in the middle with the carotid and optic protuberances laterally, between them the optocarotid recess, below the clival, and the upper part of the glanum sphenoidal. And this is another image from the anatomical dissection. And this is a video clip where, you know, what has been important. We had a contribute from our ENT colleagues, but we gave them a very important concept, the possibility, the need to work with 2 hands. That's the microsurgical attitude we learned from our teachers, and we have not changed in our work. You see, this is a microadenoma. You see on the left the bulging of the carotid artery. And we use this approach for non-functioning pituitary tumors. We use for CTH secreting tumors. We do use for GH tumors, secreting tumors, together with drugs that combined with the approach give the patient a good life. And also for adenomas. In the first instance, we thought that the drugs bromocriptine and then cabergoline took our work aside, but it was not like this, because 15% of these patients do not respond to medical treatment. Sometimes there is a chiasmatic compression that needs immediate relief, and in other conditions we have a pituitary apoplexy with chiasmal offense, and also sometimes with the oculomotor nerve compromission. So we need to perform our surgery. And the therapeutic goals are the ones we can see here: the relief of the mass effect, normalization of the hormonal hypersecretion if present, if possible, the restoration of normal pituitary function with preventing the recurrence of the tumor. And we always give tissue for molecular studies, which is in some instances are going to replace our work. The best results are with microadenomas. In the other conditions, we need to complement our work. But moving to the extended approaches that I am going to in some way to speak, we understood in 2002 that there were great possibilities of the approach, that we were not anymore working on the cella, but there was a world around the cella. And Gabrizzada made this title, Raising the Bar, because in some way what happened with the jump, that this kind of work that's not different from the ventral jump changed the possibility of going higher than before and expanding the horizons, because there was a world around the cella, above the cella, below the cella, in the viral area, up to C2. And laterally to the cella, we have been speaking about cavernous sinus invasion. And so also the indications about different pathologies have greatly extended. And I will try to shortly show what I have written here. There are different models in different anatomical districts. And if we go above in the tuberculum cell planum sphenoidalis area, you see here that the area of bone you are going to remove starts from the, I would say, from the upper or the middle of the cella going above. And also the area of the tuberculum cell that's seen differently from below. It's a notch. We named it supracellular notch. Gives different possibilities of approaching the pathology we find inside, according to a different sphenoid sinus configuration, which gives a working area. You see, very good in some instances, very bad in other instances. If you see the image on the right for meningioma, there is a long tail in both directions. So you have to consider this, including the shape of the sphenoid sinus. And there is we studied these anatomical triangles and quadrilaterals, and to know exactly what we are having behind the approach, considering that we do not have to cross the nerves. Otherwise, there is a sort of paralysis. You can work on the nerves, but always in bimanual dissection, and knowing that these tiny small vessels perforators sometimes can give bad surprises, coming from above, coming from below. There is no difference, but we need to know, as Dr. Loz said, we have to remember after surgery, the sodium and potassium concentrations and water input. And we might have bad surprises if we don't take care of these vessels. And if we don't remember exactly the biology of the lesions, it's useless to go inside the cavernous sinus and to do artificial works if the biology doesn't support our kind of work. Our series is nothing as compared with the work of Dr. Loz and the giants before me. So, but it's a good experience, and it's a good experience because many people were laughing at our work in the former times. So it's always important to have seen what was happening after the first moments. And going to the extended approaches, we can speak of adenomas and other entities. It's important to say that's not important, the dimension of the adenoma. Giant adenomas can be safely afforded by this way, but what is important are the relationship of the adenoma with the surrounding structures. I will show you one or two cases. You see this pituitary adenoma, and you always see two instruments in the cell. A microsurgical attitude is confirmed as if we were working from above. And now, after the cellular removal, we extended the approach above, and you see that we could find some sort of capsule above the adenoma. So it's a gentle work of with two ends of traction and counter traction, and this is the result after surgery with the complete removal of the tumor. And this is another case. We had a very clear, consistent capsule of the tumor, and you see here that we could dissect the tumor from the pituitary, leaving aside the pituitary stalk with by manual dissection, and you see suction and elevator, and you will confirm at the end of this video. You will see the postoperative control that's real satisfactory. You see in which condition the optic nerve was before surgery. And this is the image after surgery with the pituitary stalk and the pituitary gland. But in our experience, craniopharyngiomas, which is a very difficult tumor, and as Cushing said, the most forbidding of intracranial tumors, is giving us the best satisfactions. It was not considered to be amenable to this kind of surgery by giants of neurosurgery. But even Chirich, for me, has been very inspiring. His presentation in 1979 at the CNS, where he gave a very good lesson about the anatomy of the anatomical relationship of the craniopharyngioma with the arachnoid endopia, which also a Spanish group is now Prieto and Pascual. Yeah, they are studying properly recently. And we think that considering our experience, this is a series of our conjoined group together with the Bologna group, but also an international consensus that were made in 2019 about craniopharyngiomas. I think that today can be considered in most of the cases the preferred way of approach. The craniopharyngioma is a benign tumor but with local aggressiveness, extremely variable in the pattern of growth, and a behavior that's some way unpredictable. For years to stay quiet and then starts again. So we need to obtain a total removal of the tumor, but we have to balance between total removal and possibility of damaging the patients. So we need to consider the tumor topography, the adherence to the structures, the size and the consistency. And today we could say that also the prefixed chiasm, it's not an absolute contraindication for an extended approach. And which it's important to know the position of the stalk, of the pituitary stalk. And also what to do with the pituitary stalk in order to prevent the recurrence. We have used frequently also in craniopharyngiomas involving the third ventricle, as you can see in this case. And I'm going to show one of our cases where you can realize that with the removing the craniopharyngiomas, you obtain step by step the possibility to proceed along the surgery. The first steps that give the possibility, together with the technology you see here, the Cavitron that helps in having a first piecemeal removal, and then with the great patience and not striving on the same point, but also being able to move to another side of the tumor and then to go back to the former trouble, with respecting obsessively the floor of the third ventricle. This has been our main issue. And you see here in the ventricular craniopharyngiomas, in our series, we have made standard and extended procedures. Standard procedures were done also in former years quite often by experienced surgeons. But now we have done almost 100 cases of extended approaches. And we consider that also the Achilles heel of the approach that was CSF link has been is not anymore a problem, because we reconstruct with the flap, with the fat, with the nasoseptal flap. And another small trick that the day after surgery we have the patient leaving the bed. We are not, this is what we do, and I will show you with a video clip, but just the fat as a corkscrew, as a cork inside the approach. You see where the letter B is here, half inside and half outside, and then the nasoseptal flap. I will show you no anymore multilayer reconstruction, no anymore gasket seal closure, no anymore sphenoidal balloon. And here it should be the image of the closure. You see here the chiasm. We put the fat half inside and half outside the hole we are made. Or some just a few drops of fibrin glue, and then the nasoseptal flap. The nasoseptal flap we used to harvest just at the end, at the last minute, and small sponges inside, and this is the closure. Then the day after, you see small sponges, and the day after surgery, we made a CT scan to see the amount of air that has entered the skull. But if we change the position of the bed of the patient, now we are able to have much less air than before, because in former cases we had a sort of pneumocephalus. where we are moving, it's hard to say. Courtesy of another great mentor, Dr. A, Dr. Apuzzo. I don't know. I'm not able to tell you. I tell you that we are now studying together with the pathologist and the neuroradiologist the possibility to understand even the molecular subtypes of some pathologies in order to know before what is the need to, which way to be aggressive or less aggressive, to know as many more possibilities in advance. Because the teamwork and the great leaders, as we have been lucky to have, permits us to be very positive concerning our future. Thank you very much.
Thank you very much, Professor Capabianca, for this wonderful talk. I think there are many issues and probably many questions. Maybe is there any question from the other moderator or panelists of the speakers?
Miguel, may I?
Sure. Please.
Thank you, Prof. Capabianca. That was a wonderful talk. And also thank you for all the work. I remember all the beautiful books with all the illustrations and high quality pictures. I have a question about one of the things you mentioned in the talk about the extracapsular recession of non-functioning pituitary. Is it something which you decide in advance, or you decide on table whether to go extracapsular for such tumors?
No. We decide during surgery. During surgery, no doubt.
Okay.
Thank you. Okay, Professor Canan, of course.
Yeah, Pablo, I want to ask you the industrial part of it, the evolution. I remember the very first cases in the modern era from the 90s until now. It's almost 30 years plus. Did the companies evolve properly and fast enough with the technology? Because I'm seeing the endoscope almost the same, little bit with the digital camera holder. Just recently, they are coming with something. We are missing a lot of things that can be done. I'm sure the clinician or the surgeon, they have a lot of idea. Do you have the yield from the company to yield on that one and progress a little bit rather than keeping the same tube that I know from Professor Auer from 40 years, the same tube of endoscope, and nothing strong came out, even for this irrigation system they have. I'm sure now many of us, they are taking the irrigation because it's only disturbing, and we do side irrigation. And the holder, because I saw one of the slides you are doing, even transsphenoidal, you are not doing the dynamic endoscopy, you are fixing the endoscope and you use the bimanual technique.
No, Imad, we don't use the holder, always free hands. But
yeah, dynamic.
Always working with two people, and there is such an identity of view that we need very few words. Dr. Cavallo, Dr. Solari, they work so nicely together that they don't need to speak very much. No holder. But to be honest with you, I don't think that the companies have done something, but have not done exactly what we expected from them. Also, the 3D was a true failure. The progress in our experience, the progress has come from the 4K concerning vision, but maybe in the next year, now this terrible moment gives us the opportunity to build a new future. And also technology will support, because we need to do a lot of new things. And I rely on the new generation. I have been lucky. All the people, besides Dr. Cavallo, that's now it's a senior of our group and is much better than me. But many other subjects are so good and inspired that I rely on them. They will permit further progress in our work.
What about the fluorescein guided evaluation of pituitary? How do you see it? Because I tried it, it was not very impressive. And what is your take on that?
Agree with you. Not very impressive.
Not very, yeah. Thank you.
Thank you very much. I have one short question for Dr. Capabianca. Well, our experience using the fat, when the fat is inside the intradural space, is that in reoperation, you can have trouble because of sticky planes and things like that. Are not you afraid of that just in the case of potential recurrency in craniopharyngoma?
No, because there is a resorption, Miguel. We have had also this experience, never had any trouble in removing what was left by the resorption.
Thank you very much.
May I ask one more question on the craniopharyngioma, the same subject, Miguel?
Sure.
Yeah. How do you handle a heavily calcified craniopharyngioma? You still go from below, or you have a second thoughts if it's centrally calcified in the center?
It's hard to remove, Imad. It's not easy, but we try to bite with the cups, and we always try when there is a lateral expansion of the tumor or vessel encasement, we don't go transsphenoidally. But I would say that more than 90% of the craniopharyngiomas we approach from below.
Okay, thank you. Well, I think we have to move, but before that, Paolo, I'd like to thank you again because, my friends, my very early exposure to endoscopic pituitary surgery was in Naples with Professor Capabianca. I'm so grateful to you. Thank you very much, Paolo.
I am grateful to all of you because I found friends everywhere. For me, it has been a great period of my life, and I always want to thank you. Grazie.
Thank you very much. Grazie, appreciate. So thank you again. Wonderful talk and wonderful discussion. I think it's time to move to the next presentation from Professor Takeo Goto from Keio University in Osaka. Professor Goto is going to speak about endoscopic approach of complex pituitary tumors with cavernous sinus involvement. I think this is a very hot issue, and for sure there will be a very interesting discussion about when and how to try to remove this endoscopic, cavernous sinus extension of the lesion. Professor Goto, please.
Thank you, Professor Miguel. I feel very honored to have the opportunity to present my work in front of many experts of pituitary surgery. Today, my topic is endoscopic approach of complex pituitary tumors with involvement of cavernous sinus. As already we know, the endoscopic endonasal approach can provide the wide surgical view to the paracella area. So recently, normal pituitary adenoma can be safely removed with endoscopic TSS. For example, in the era of the microscopic TSS, surgical corridor is this. So I always feel that to remove the upper part of the tumor are a little bit difficult. But recently, endoscopic panoramic view can offer the wide surgical view to the upper margin of the tumor. So this kind of the tumor safely resected out by the endoscope. For example, this is a simple case of the pituitary adenoma, but upper part of the tumor slightly extended to upward. But recently, this kind of the tumor safely resected by the endoscope. Also, this is a recurrent pituitary adenoma with a supradiaphragmatic extension. But the region that localizes the midline. In such case, also, we can safely reject it by the endoscopic endonasal approach. But on the other hand, complex pituitary adenomas like this with severe cavernous sinus invasion or severe suprasellar extension, surgical removal remains the challenging. So today I will explain how to operate this kind of the tumor. At first, this 60-year-old female referred to us with a chief complaint of the left oculomotor nerve palsy. This tumor protruded to the subdural space through the superior wall of cavernous sinus. It's the cause of the oculomotor nerve palsy. Professor Miranda showed a nice illustration, the relation between the tumor and the superior wall of cavernous sinus. In our experience, in most cases, pituitary tumor protruded to the subdural space through the superior wall of cavernous sinus along the oculomotor nerve. This is the oculomotor triangle. So to remove this part, I always pay attention to the intercranial ligament. I cut the dura mater diaphragm along the intercranial ligament and then cut the intercranial ligament to open the oculomotor triangle. After that, I remove this tumor. I will show how to remove this tumor. At first, of course, wide opening of the cella floor is very important. And then I resected out around the midline. Fortunately, this tumor was very soft, so it's not difficult to remove the midline part. But this is the superior part of the tumor. I carefully mobilize. Now the midline tumor completely resected out. After that, I go to the lateral side. This is a carotid artery, and this is a cavernous sinus. I always very carefully not to pull out the perforator from the carotid artery. I meticulously identify the perforator and coagulate it. Now we reach around the superior wall of cavernous sinus. This is an oculomotor triangle. The tumor protruded to the subdural space through this hole. So I cut the diaphragm along the intercranial ligament. This is a subdural space. I confirm the optic nerve and carotid artery. This is an optic nerve, and this is a C2. Now I cut the diaphragm along the intercranial ligament. So gently pull the tumor downward. This dural cutting is very important to go to the lateral side of the tumor. This is the intercranial ligament connected the anterior cranial process and posterior cranial process. This is a tumor protruded to the subdural space. And then I cut the intercranial ligament. After cut this ligament, tumor come down to downward. So we can gently remove out with a suction. No need to curating. So the superior part of the tumor successfully resected out. And then I open the oculomotor triangle to confirm the third nerve. This is the left oculomotor nerve. Now I confirm the third nerve completely decompressed. This is a optic nerve, and this is a third nerve. Now I confirmed all tumor was safely resected out. But in our procedure, we made the large dural defect along the diaphragm. So we need the water tightly seal this defect. I put some the suture along the diaphragm. This suturing technique is very important to prevent the CSF leakage. No need to water tightly seal, but after put some stitch, I insert the fat tissue to subdural layer. This fat packing is very important to seal the dural defect. I put the suture again. And then insert the fat tissue. This needle folder is very useful to perform the suture along the deep part. So now the dural defect almost watertightly sealed. And then we cover this defect using the fibrin glue and artificial material, and then cover the mucosal flap. After that, tumor was totally resected out. This is not tumor, this is a fat tissue inside the subdural layer. Postoperatively, her third nerve palsy dramatically improved within 1 month. This is another case. This 70-year-old female referred to us with the chief complaint of the abducens nerve palsy on the right side. I think the abducens nerve compressed along the Dorero canal, so decompress this part is a key issue of this surgery. Usually, abducens nerve go into the cavernous sinus through the Dorero canal. So decompress this part is a key point of this surgery. This is a surgical view. I mobilize the pituitary gland to the left side, and I remove the tumor around the clivus. And this is a carotid artery on the right side. Usually, we have to carefully remove the tumor along the carotid artery. I just use the suction, not curate, and not pull out the perforator from the carotid artery. This is a small feeder from the carotid artery. We preserve this, and then peel off the inferior wall of the cavernous sinus to the lateral side. Of course, we encounter some small venous bleeding, but this venous bleeding can be controlled using the surge flow or flossing. Now I confirm the sixth nerve along the Dorero canal and remove the tumor along the carotid artery. This is a perforator from the carotid artery. Maybe this is an inferior hypophyseal artery. I coagulate. And this is the sixth nerve along the Dorero canal. This is the interdural space. So now I confirm the sixth nerve successfully decompressed just behind the carotid artery. Venous bleeding controlled from using the flossile. And exposed carotid artery completely cover the mucosal flap after the surgery to prevent the infection to the carotid artery. Postoperatively, tumor successfully decompressed, and her abducens nerve palsy improved. But how is this case? This is a very large pituitary adenoma with cavernous sinus invasion. In such case, transcranial approach alone is very difficult. And also, endoscopic endonasal approach is not sufficient to this case. So I combined the transcranial and endoscopic approach at the same time. This is an endoscopic view. At first, I widely expose the dramata along the right cavernous sinus. This is then I also perform the front temporal craniotomy and open the Sylvian fissure on the right side. This is the tumor in the Sylvian fissure. I dissect the tumor capsule. Then I start to remove the tumor from the nasal side. Now the tumor around the cella floor was totally dissected out, and this is the optic nerve. I remove the tumor along the optic nerve. And this is the cavernous sinus. And now we reach the superior wall of cavernous sinus. This is the dural defect. And this is the carotid artery. I carefully remove the tumor along the carotid artery, not pull out the perforator from the ICA. Then I cut the inferior wall of the cavernous sinus and go to the lateral side of the carotid artery. Now identify the B2 and also confirm the B1. This is a olfactory nerve, and this is the optic nerve. This is the superior wall of cavernous sinus. I open it and confirm the third nerve. I resected out along the third nerve, and the tumor was successfully decompressed. Also, optic chiasm and pituitary stalk was decompressed. Then I confirmed the abducens nerve along the Dorero canal. So I removed out. This is the third nerve, and this is the abducens nerve. I go into the subdural space and remove the tumor very carefully. This is the icon, and this is the tumor around the subdural space. This is a suction tube from the cranial side. And finally, tumor was successfully decompressed. Dural defect meticulously sealed through the nasal side and also transcranial side. So the tumor was almost totally resected out, and also abducens nerve palsy improved. How is this case? This patient showed a very severe visual disturbance on both sides, and tumor extends the subdural space severely. In such case, I use a combined approach, endoscopic keyhole and endoscopic endonasal approach. At first, I cut the skin incision along the eyebrow and make the small keyhole craniotomy around the left frontal bone. The size of craniotomy is about 3 centimeters. And then go into the subfrontal area. I use 2 endoscopes, transcranial side and transnasal side. I gently retract the frontal lobe and now reach the frontal base. This is a surgical view from the transcranial side. I dissect the olfactory nerve along the frontal base and go to the deep side. This is a very spreaded optic nerve on the left side. And I start to remove the tumor lateral side of the optic nerve. This is a carotid artery. And this is the left optic nerve. Of course, the left side already blindness. So no need to strong care to the optic nerve, but I removed out along the left A1. This is the ICA M1 left A1. This case, the tumor severely invaded to the ACA, so we have to carefully dissect the tumor along the ACA. This is a suction tube from the nasal side, and this is the cranial side. We use the whole surgical instrument to carefully remove the tumor. This is a surgical view from the nasal side. This is the left A1. I resect the tumor along the left A1. And this is the tumor in the interhemispheric fissure. I resect it out very carefully and expose the left A2 portion. This is the left A2. This is the A-com, and this is the left hypoplastic A1. And then this is the right A1. Right side is the dominant. I carefully removed out, but tumor capsules, of course, strongly adhere the artery and the perforator. So I left behind some tumor capsule along these perforators. But I confirmed the tumor was successfully decompressed. Postoperatively, the tumor was successfully decompressed, and we managed to preserve the right vision. But in some cases, we have some encounter some complication. This is a large recurrent pituitary adenoma, and the tumor continue growing up inside. So we talk the patient and decided to operate this case by the combined approach. We carefully operate, and we, I thought during the surgery, I meticulously remove out the tumor and decompress. And we not encountered bleeding, but the post-operatively MRI showed infarction along the basal ganglia. The cause is a vasospasm, or I'm not sure, but anyway, we make the infarction around this area. So post-operatively, patient shows transient left hemiparesis for 4 weeks. So he needs the rehabilitation. And also he suffers transient right third nerve palsy and sixth nerve palsy. So I could not conclude what is the best treatment to this case. So my take-home message to young neurosurgeon is that complex pituitary tumors remain surgical challenge even after development of the extended endonasal approach. So surgical planning without much consideration might cause a severe complication to the patient. Thank you for attention.
Professor Goto, thank you very much for this elegant presentation. Thank you very much for these amazing videos regarding surgical removal of such complex cases. I think you have shown the most complex pituitary cases. Maybe there are many questions from the other moderators or speakers. I have one question. Before you make the decision for such a, let's say, extreme kind of operation or combined operation, what is the indication are done in recurrent cases after radiation or hormone-produced tumor? Or do you, in other words, do you use regularly this kind of operation in non-functioning pituitary adenoma instead of radiation therapy, instead of, let's say, one stage of transnasal classical decompression of the optic pathways and then radiotherapy? What is your policy regarding that? Thank you.
Thank you, Professor. I think it's very difficult to decide the surgical approach. Of course, in some cases, I consider the radiation, but if a patient is symptomatic, severe visual disturbance or cranial nerve palsy, third nerve palsy, or abducens nerve palsy, I plan the decompression of the tumor. And in addition, of course, at first we consider the staged surgery, but in case of the very large tumor, residual tumor shows a post-operative bleeding. It also causes a deterioration of the symptom. So the balance of the surgical resection very, very difficult in case of the complicated pituitary adenoma. So I not have the a precise indication. Always I discuss our group and decide the surgical strategy to this case.
Thank you very much. I have another question that maybe also for the other presenters, but in such a, let's say, risky cases for CSF fistula, do you still use, in some cases, lumbar drainage, or you have abandoned, as seems to be the current trend, have you abandoned the lumbar external drain?
I think that it's also controversy. I don't use lumbar drainage after the surgery, but I put some suture to the dura mater. To put the tension of the dura mater is very effective to prevent the CSF leakage. And also I use a large mucosal flap in case of the extended approach.
Okay, thank you very much. Thank you very much. Impressive operation. I think this is something amazing you do in such a complex cases. Is there any question, Professor Kanan or Professor Labadi or any other person? If not, we will move to the next presentation, not without thanking again Professor Goto.
Miguel, I'm sorry to interrupt. It looked like Professor Falbush had a question.
Yes. Amazing techniques, fantastic anatomical knowledge is just maybe the presentation for the neuroanatomy committee. My question is, how much does consistency of the tumor relates to the outcome or to completeness of removal? What are you doing in those really very firm stone hard tumors?
Outcome is, of course, constancy is very important. If the tumor was soft, of course, surgical removal is relatively easy. But in case of the recurrent tumor, some part is a fibrous stick and some part is soft. So it's very difficult to decide when we stop the surgical resection. So it's very difficult to answer the question.
I understand.
Miguel, may I have a question for?
Sure, you can.
Professor Takio, thank you for this really very impressive and challenging, complex surgery. It's really great. But my question is about the quality of life of these patients. Before to operating them, of course it's mandatory to give him all the to talk him about all the complications, and they accept easily to be operated and to accept all the complication, because I think it's not easy to we show us the case when there is a contusion and many complication, hemiparesis and many palsy nerves. And
thank you for the question. Of course, I put the priority to preserve the patient ADL. So my philosophy is a maximum resection with functional preservation. So the last case, of course, I cause transient hemiparesis for 1 month. But if the tumor severely adheres the vascular structure or invades the cavernous sinus, of course, we left behind some tumor to preserve the patient quality of life or neurological function. Because radiation also effective to pituitary adenoma. So preservation of the neurological function is the most priority of this surgery. Thank you.
Thank you.
Thank you very much. Is there any other question to this interesting presentation?
No.
Okay. Thank you, Professor Goto. Congratulations again. And let's move to
I have one question, Miguel.
Sure.
Yeah. With this invasive pituitary adenoma and the cavernous sinus, what was the MB3 index on these giant tumors you were dealing with infiltration of the meninges? Was it MB3 above 3%?
In our cities?
No, the few cases you showed, they are giant invading cavernous sinus and invading dura. And usually we like to check the MB, sorry, and how high is the MB index?
MIB1 index, okay.
MIB.
In some cases, MIB1 index is very high, but even the MIB1 index is low, some tumor invade the cavernous sinus severely. I think that not so strongly relate the MIB1 index and cavernous sinus invasion. This is my impression.
Okay, thank you very much. Any other question? Any other comment? No? So thank you, Professor Goto, congratulations. And now let's move to the next talk. This is something very nice for me, just to have the pleasure to make the presentation of Professor Fred Gentili. He doesn't need any presentation. You all know that he's one of the giants in pituitary surgery and endoscopic surgery, and also open skull-based surgery. And he's working, as you know, at the University of Toronto. He's a very good surgeon. He's a very good friend. He's a very good person. What else could I say before presenting the speaker? So Fred, please go ahead with your presentation regarding the management of giant and recurrent pituitary tumor.
Can everyone see my screen?
Perfectly well.
Thank you, Miguel, for those very kind words. And I want to especially thank Imad and as well as Vladimir and the entire WFNS Neuroanatomy Committee for putting on these very, very educational and important webinars. I think, you know, they're very important at any time, but particularly in this terrible pandemic that we are doing. These are very, very useful for young neurosurgeons that can see these from all over the world. They don't have to travel thousands of miles. So thank you again, Imad and Vladimir. And also to the other speakers, all of my friends, excellent presentations. So my talk this morning is on the management of recurrent and giant adenomas. Now, there's a number of controversy and challenges in pituitary adenomas. Many of these have been addressed today. The whole issue of diagnostic controversy, the predictive markers, the management of cavernous sinus that we just saw now, the role of radiotherapy, indication for craniotomy, but also very challenging are the management of, the management of recurrent and also the management of giant adenomas. So this is a patient that I operated on back in 1990, 30 years ago, with a pituitary adenoma, microsurgical transsphenoidal surgery with this rather large adenoma presenting with vision. This patient, sorry. I don't know what's happening with my thing here. 30 years later, as you can see, no evidence of recurrence of normal pituitary function. Now, I think all of us would love if all of our patients were like this. But unfortunately, we know this is not the situation in the majority of cases. And in fact, this is the one that's more common. Operated on very similarly, 1993 with a microscopic approach, had a recurrence after 4 years, did a repeat microscopic transsphenoidal. He then progressed. We watched him for 10 years And then he'd had disease progression, and we did an endoscopic approach. I started with my endoscopic series. And then again, 7 years later, further evidence of growth and vision worsened with repeat endoscopic resection. So 2 microscopic, 2 endoscopic, and then we watched him a little bit with the residual disease in the cavernous sinus and had further progression. So what do we do now for this patient? Well, we'll come to this later. So recurrent pituitary adenomas, unfortunately, are common. The incidence can be up to 50%, and those with cavernous sinus involvement at 10 years can be 80%. The peak time to recurrence is 1 to 5 years, but the time to recurrence can be extremely long, and other presenters have talked about this, the importance of long-term follow-up in pituitary patients, because they can have recurrences at a very delayed fashion. These are difficult management problems. We know that repeat surgery is always challenging and not as easy to perform as a primary surgery, and we know that they're associated with increased morbidity and decreased favorable outcomes. And if you look in the literature, interesting, there's no major international consensus on the optimal management of residual recurrent pituitary adenomas. In other words, the role and timing of repeat surgery. What about radiation, medical therapy? But we do know that the management often requires a multidisciplinary approach, that surgery alone is often not the answer. So the risk factors for recurrences, of course, we all know this: incomplete tumor resection at the initial surgery. There's a tumor biology, and invasiveness is important, particularly infiltration of the adjacent structures, cavernous sinus, carotid artery. And very important is the experience of the surgeon. This we know now. And very important is the duration of follow-up. So what are the treatment options? We all know this. Of course, we can watch these, wait and see. We can do repeat surgery. We can do repeat surgery with radiation. Radiation alone has been used for recurrences, medical therapy, chemotherapy, and combination therapy. Now, our series now approaches almost 2,000 cases of endoscopic resection of pituitary adenomas. And the questions we wanted to answer early on when we did this was to look at could the endoscopic technique reduce the incidence of recurrence and improve our ability to deal with recurrent adenomas? So early on in our experience, we reported this back in oral neurosurgery in 2012. We looked at a very small series of about 39 patients that had a previous microscopic. You can see the demographics here, non-functioning and functioning, but also look here that 43% had already frank cavernous sinus invasion. So this is a typical patient that you see here. Not sure, here we go. The beauty of the endoscopic, and this has been emphasized, is the wide panoramic view that you get, that in this patient, you can see the lesion was adjacent to the cavernous sinus on the left side. And this allows us, here's a beautiful hardy type of pituitary microadenoma that you can see very nicely, that we can then take off, and I won't bore you with the video all the way, but here we are taking it off the medial wall of the cavernous sinus, all the way here, and then after the removal of the tumor, you can see here, beautiful view. You know that you've now got a nice total removal of this tumor, carotid artery, and this patient postoperatively, you see, had urinary freeze cortisol over normal. 7 year, he remains in remission. And just a comment about cure in functioning tumors. We do not talk about cures in acromegaly or Cushing. We talk about remission because we know that these can recur at 5-10 years. This is a patient with the acromegaly, persistent acromegaly after microsurgical. And the problem here, of course, was this conchal type of sphenoid, bone all the way around. And the endoscopic approach, again, allowed us to drill down widely to allow us to expose the cellular area. And then after, again, the removal, you can see, again, a nice removal. Again, the medial wall of cavernous sinus wall cleaned. And this patient is post-op 5 years in remission. Finally, this patient is a 53-year-old male, had a microscopic with partial removal. And the problem here, of course, was these kissing carotid. Look at you have about 3 or 4 millimeters that you can deal with here. But the advantage of the endoscopic approach is that it can give us an ability to do a little bit of an expanded transtubercular approach that allows us to go above. And again, very quickly, you get a very nice exposure shown here. And this is basically, as we're drilling off, these are the carotid arteries here. And this is us with the Doppler ultrasound identifying these. And then we basically go above and do a little bit of planar exposure to allow us to get a decompression of this patient whose vision was the major issue. And just go quickly there, reconstruction. So this patient, if you can see, improved in his vision. We did not get the total removal, as you can see here. And our plan here is to observe. So this is the results of our series. As you can see, the gross total removal rates are 54. Not high, but these are recurrent tumors, and 43%, as you recall, had frank cavernous sinus invasion. The gross total removal rates were very satisfying in the non-functioning adenoma, 86%, as long as there was no cavernous sinus invasion. Once a tumor goes invasive to the cavernous sinus, I must say I have the philosophy opinion that it's not really possible to get a gross total removal. In functioning adenomas, you can see Cushing's disease, 75% remission, and growth hormone, 44% remission. Now, you can't say very much with a series of 39 patients or so, but our feeling was, at least looking at the literature, that the overall results of these were better than in most reported series of recurrent microscopic surgery. Of course, the cavernous sinus invasion was the major predictor of outcome. And this is Capabianca's and Cavallo's group in Naples. Very similar results. Growth total resection was 62%, 59% from a previous, and 74% it was a previous microscopic approach. This is a systemic review, and of course we always have to be careful about systemic reviews. Sometimes they cannot be, they can be biased to one or the other, but 15 studies. The remission rates, these are non-functioning adenomas. The remission rates for non-functioning was 76%, 44% in growth hormone, and Cushing 55%. This is our series that I want to just spend a little time on, because this is just recently published in World Neurosurgery in October. And what we wanted to look at was long-term follow-up, because we knew that these patients recur. So a 2-year, 4-year, 5-year follow-up is not adequate to really find out the injury. So we wanted to follow them long-term, 10 years, and you can see 2005, 2015, 269 patients. You can see the demographics here. These are largest tumors, 2.5 centimeter medium, and the results that you can see here of the pathology. What are results? Well, again, not terribly exciting in the sense only 54% did we feel we were able to get a gross total removal, a true gross total removal. And again, you have to understand that the cavernous sinus invasion was present in almost 50% of patients. Now, the gross total removal rate varied according to cavernous sinus involvement. Those with cavernous sinus involvement, we were only able to achieve 27%, and I think that's optimistic, versus 72%. Also, we know that recurrent surgery carries more complications. So hypopituitarism, one or more hormones, 11% after the first surgery, but 21% after the second surgery. What did we do with what about the number of recurrences? The overall recurrence rate was about 21%. But the recurrence rate was 22% at 5 years, but when you follow them to 10 years, it doubled. The median time to recurrence was 10 years for patients without cavernous sinus involvement and 6 years for those with cavernous sinus involvement. A third were symptomatic, usually vision, but 2/3 were asymptomatic. The risk factor for recurrence, we all know, these are things that we all know. Size, of course, is very important. Cavernous sinus invasion, anterior skull base extension, residual tumor after previous surgery, all significantly associated with recurrence. In a multivariate analysis, age, tumor height, cavernous sinus involvement, and residual tumor, again, associated. Interestingly, and this surprised us a little bit, in general, tumor pathology was not found to be a significant factor, although the silent corticotroph subtype adenoma had a higher tendency for recurrence. How did we manage these? Well, 52% of patients required a second surgery, primarily because of vision or to present visual complication in a lesion that was continually growing. Here, the gross total rates, as you see, very poor. Only 28% did we feel we could get a total gross total removal. 15 patients underwent radiation, 9 gamma knife, 6 fractionated, 10 after the first recurrence, and 5 after the second, with a relatively good tumor control rate. So let's go back to that patient that I operated on. 2 microscopic, 2 endoscopic, with now residual in the cavernous sinus. Well, in my mind, and you know, I may be wrong, but I do not think that surgery has a really is a real cure, at least solution for this patient. And so we recommended radiation therapy, IMRT radiation, and he now 5 years stable disease. So this brings us to the whole issue of radiation pituitary adenomas. We know that they have a role to play, no question about that. A variety of modalities have been used, as you can see here. What does the literature suggest? Well, in terms of remission rates in functioning acromegaly, roughly 40 to 60%, Cushing's 40 to 50%, but in non-functioning, you see very high control rates at 5 years, 88% control. This is a literature review by Jay Lawfer and his group looking at evidence synthesis that there is a high success rate in controlling tumor growth up to 80 to 97% in most series, regardless of the radiation technique used or the adenoma subtype. Hypopituitarism, as we all know, is an expected result of radiation therapy, but overall other treatment-related adverse effects were relatively low. And this is a series with a meta-analysis of non-functioning adenoma looking at 2,000 cases. The 5-year, they use also stereotactic as well as a hypofractionated stereotactic radiosurgery. 5-year low control rates with stereotactic 94% at 5 years, 97% at with hypofractionated. 10-year, of course, it drops a little bit to 83%. There's no question that stereotactic radiation is an effective and safe treatment for patients with non-functioning adenomas, recurrent adenomas where surgery is not feasible. Now, I don't have time because of just the amount that I have, but we all know that the recurrent tumors, there is a medical management. These have all been used for different functioning tumors, but we also know that these are used now, medical management for non-functioning. So our endocrinologists will place patients on folate antagonist, including dopamine agonists for recurrent pituitary and non-functioning pituitary adenomas. So this is a summary of current guidelines. I said there weren't many guidelines, but this is from the Congress of Neurological Surgeons and the European Society of Endocrinology. They recommend that a dedicated pituitary surgeon's opinion be sought on repeat surgery prior to proceeding with adjuvant therapy. So now you have to be an expert that can say, no, I can reoperate on this as opposed to going immediately to radiation. Patients should be managed in a setting of a multidisciplinary team. Repeat resection is recommended for symptomatic recurrent or residual tumors, and that stereotactic surgery is recommended for residual tumors. There's still controversy. What do? Do you do it immediately after the surgery when you know you have a residual, or do you wait for a recurrence? There's a controversy on that. So getting now to the management of giant pituitary adenomas. Again, the incidence is roughly 5 to 14%. We know these are difficult management problems. They have increased incidence of neurological endocrine dysfunction. They have capacity for aggressive local growth. They're surgically challenging. The growth movement rates are usually low, often less than 50%, with increased treatment morbidity and morbidity, with increased recurrence rates. And again, the overall treatment outcomes are often not as good as in the smaller lesions. And again, the optimal management is really not clearly defined. Again, the same options for giant as you have for recurrent tumors. And this is, I just want to show this patient is a 58-year-old patient, very briefly, with this tumor that we did using an endoscopic approach. And this is just to show you very quickly, we do a middle turbinectomy on these giant tumors. I'm very liberal with middle turbinectomies, but for these giant tumors for sure. And then the key is this nasal septovascularized flap that is very important in these giant tumors that sometimes the CSF leak rates are a little higher. And then basically the key is like all of this to get this nice wide sphenoidotomy carried out. And then coming here, we see removing the thinned out bone. And then the key is, as noted, I think from Ed Laws, you have to do a wide exposure from medial wall of cavernous sinus to medial wall of cavernous sinus, to, from the superior to cavernous sinus to inferior cavernous sinus. And then the resection is done in layered system. And if you can get this nice diaphragma to descend, all the way over here, sorry. Here's the patient's postoperative course on the first day. We do, I think some say we do a postoperative scan on the first day post-op to look at any bleeding and so forth that we can compare. We don't do MRI scans. I agree with Dr. Laws that it's useless up until 3 months. But this patient, as you can see, 2 years, nice resection. This is a patient, another patient, 74-year-old gentleman, again with this large tumor. And again, just to very quickly go through. Again, wide exposure, and just to show our technique for these and outdoor. The key is to do a layered approach. Don't go immediately medial to go up because you get the diaphragma that descends. I go inferiorly, then go up the medial wall of cavernous sinuses on each side, and then sometimes you can find this pseudo this plane that allows us to do an extracapsular. Now in giant adenoma, it's not very common, but occasionally even in the giant, you can do an extracapsular removal. This patient you see had improvement in his vision. And the other thing I would just want to say, you'll see here the postoperative day scan. It's nice to see this. This patient, however, had improved vision immediately postoperatively. So do not panic and say, you know, he's got this, he should rush back. If the patient's vision is better or stable, this is we see this sometimes, and within 6 months, as you see of the MRI scan, but within a week we did it, that hemorrhage has reabsorbed, and you can see the 6 months here, a nice resection. Finally, this patient here, as you can see, with this large tumor going anteriorly, well, I think before endoscopic surgery and expanded approaches, you might say this would need a craniotomy. Well, now with our experience with the expanded approaches that you can see here, using a transtubercular transplant, we can get a very nice resection of these large tumors. And just again, take you quickly over here as we go up. And then this is our transplanter approach. Here's the dura. We're cutting the dura here. And then basically you deal with it with just like you would under the microscope. Bring the tumor down. You could debulk it more until ultimately we have gone above the tumor, and you can see a nice view of the chiasm here and the tumor brought down, and the pituitary, the pituitary stalk here. This patient is a post-op MRI scan, and he's now 8 years and remains recurrence-free. Finally, this patient here, 34-year-old patient with an M1, headaches with this tumor, had a prolactin 20, but you know this is not a prolactinoma because it should be up in the thousands for this. And the prolactin was normalized, slight improvement in vision, 6 months. You can see residual disease. What now? So we did a expanded transsphenoidal approach for this. If you can see improvement in his vision, this was a silent subtype. These are aggressive tumors and with significant residual. What do you do here? Well, to me, with a significant residual, with an aggressive tumor, I think observation is not the way to go. And here we would go immediately to radiation, fractionated stereotactic, 50 gray, 3 years with stable disease. And finally, this one here, long-standing visual, he presented to us virtually blind with this tumor here. What is the best approach? Craniotomy, endoscopic combined. Well, we elected to do at least an expanded. Postoperatively, you can see we did not get a good removal. He had a left hemiparesis, cognitive dysfunction, worsening his vision, virtually blind. What did we do? Obviously, we injured his thalamic perforators going posteriorly here. Was this the right approach? Was the right technique? We're now basically the patient's 1 year, stable here, but virtually blind. So there are limitations of the transsphenoidal endoscopic approach: large invasive tumors, lateral extension, multiple compartments, vascular encasement. And what do? What about this patient? Large tumor going up into the ventricle here. To me, this is a bit back. He had a previous transsphenoidal. This, I think, is a patient that requires an open approach. And we did an open approach. Interhemispheric transbasal is my favorite open approach for these. You can see the tumor, and we work basically in the lamina terminalis, the third ventricle, ultimately getting a nice removal that you can see here. This patient's 15 years with stable disease. And this patient here, obviously, going out lateral like this is not a good a patient for a pure transsphenoidal approach. And so I would not do, if I can do one procedure that is good, to me, the open approach is the best procedure here. And again, here, this patient bifrontal tumor removal. After the tumor removal, and you can see the patient here, improvement, at least no change in the left eye, but improvement in the vision. So this is our series, was published back in 2014. Just very quickly to go through the definition, we use a volume base because we think it's a little bit sensitive than a linear base. We use 10 centimeters for defined as large or giant. Here's the parameters, the outcome. We want to look at extent of resection, visual changes, complications. 73 patients met the criteria. You can see here the
2 minutes, Fred, 2 minutes.
Pardon?
You have 2 minutes left.
Thank you for the reminder. The presentation, you can see the majority is visual compromise, and the average tumor size you can see quite large, 18 centimeters. This is the pathology. I don't have time. We use a pure endoscopic approach for all of these. The cranial ones that I showed you was before this series, and then we use an expanded approach in 5% of the patients. So what are the gross total removal rates? As you can see, very low, 24% did we feel that we really had gotten a gross total removal rates. If you want to bring in near total, which I don't know, people use these, gross total is only 41%. What I wanted to look at as a predictor of extent of resection was maximal diameter and volume, of course. Hemorrhagic component of the tumor. Once you have a hemorrhagic component that then has fibrous thing, it's very difficult to remove these tumors. And of course, invasion, highest NOPS grade is very important, and posterior and lateral extension. What we did not find significant of interest was that the pre-op visual acuity prior surgery, which surprised me, or prior radiation did not seem to be a significant parameter, and even biological tumor characteristic, the cell type, the MIB was not a significant factor. Is our complication rate? The improvement in vision was 73%. Interesting, even these large ones, we had 15% that did not have significant visual. CSF leak rates was about 10%. It's a series in the literature. I don't have time to go through these. Looking at the approaches, whether transsphenoidal or transcranial, again, really low total gross removal rates. So this is the conclusions that I have, is that endoscopic approaches can obtain an extent of resection equal or higher to transcranial technique for giant midline located tumors. Endoscopic approaches are safer and more effective in alleviating symptoms. Transcranial approaches are favored for tumors extending laterally to the midline, and that radiation therapy has a definite role to play in controlling residual tumor and recurrences. In conclusion, recurrent and large giant pituitary adenomas remain a significant surgical challenge regardless of the approach or technique. And however, recurrent and giant pituitary adenomas often require a multimodality approach with adjuvant radiation and or medical therapy to effect long-term control. So what we say, the evaluation and management of patients with recurrent and giant pituitary adenomas require the active participation of an experienced pituitary surgeon, as well as an equally experienced multidisciplinary team of endocrinologists, radiation oncologists, medical oncologists, and pituitary neuropathologists. So thank you very much for your attention.
Thank you very much, Professor Gentili, for this wonderful presentation, just showing your expertise and also the judicious use of all the tools for the control of such a complex tumors. I like to make some comment. I like very much your slide regarding the factors for recurrency, and it is assumed that positive immunochemistry for any of the hormones, although not being an hormone producer tumor, is associated with higher rate of recurrency. It wasn't the case in your series. Is that right, Fred?
What we found that the hormonal type was not a significant factor. That's correct. which was a little surprising to me, as I said. And also the fact that the MIB and these other factors were not. I don't know if that's a relationship to the numbers, that they're not big enough or not. But we know that, for sure with regard to remission, I looked at growth hormone rates. Remission in giant functioning tumors is very, very, very low.
Okay, thank you. I have another question. I think it's something of real interest for the youngest colleagues in the audience. What is your policy regarding the situation of invasion of cavernous sinus? Yeah. Are you aggressive as a policy or only in certain cases?
Yeah, so Miguel, absolutely. And I think it is important because we have the situations where you have the people very aggressive, going into the cavernous sinus, mobilizing the carotid and so forth. Now, I've never been a proponent, going back to my open skull base, of a proponent of radical cavernous sinus surgery. I have not. And in the pituitaries, if I have a tumor that leads me there, of course I'm going to follow it. It's already destroyed the medial wall of cavernous sinus. You go in and they're nice cyclable. You'd be silly not to follow it. But to go through to remove the medial wall of cavernous sinus, I do not do that. It's my philosophy that the likelihood of getting a gross toe removal, and what are you decompressing there? You're not decompressing the optic nerves. If the patient has a third nerve palsy or a sixth nerve palsy, by just decompressing the medial aspect, they'll improve. You saw that. So to answer your question, after a lot of that, I'm not a fan of the cavernous sinus surgery.
Thank you. This is a very interesting comment because sometimes when seeing videos regarding resection at the cavernous sinus, I very seldom see a cavernous sinus bleeding. Maybe all the bleeding cavernous sinus are here in Malaga. I don't know.
That's correct. That's correct.
Okay. Thank you very much. Is there any question? Imad, my friend.
May I ask? Rudolf
Falbush.
Yeah.
Please go ahead.
Fred, how many times would you reoperate a recurrent tumor? Does it depend on the distance? How long is recurrent free? Let us say, if the tumor reappears after 10 years, would you do it 2 times, 3 times? Or on what criteria do rely reoperations?
Yeah. Thank you, Rudy. That's a very good question because, as I say, there's no consensus there. When should you say, okay, like I showed the other one, after 4 operations, I figured, okay, that's enough. I don't want to do a 5th operation. I've come around to looking at more, what can I do in this patient? And can I get a gross toe removal? Because if I feel that, that there's a recurrence, that I look at it and I say anatomic, I think I can, help the patient by decompressing, but also get a gross toe removal, I will do that. First time, second time, maybe even 3rd time. The other very important thing, Rudy, I look at where it is. And I just told you about cavernous sinus. I'm not a keen that. So if I do one surgery and it has a recurrence in the cavernous sinus, I go for radiation. There's no use doing another operation when I know I'm not going to get a gross toe removal. So the location is very important. But if it's still midline and for whatever reason it keeps going, that you can do a good safe operation to decompress critical structures, I can still do that. But when I look at 2 to 3, after 2 to 3 surgeries, if I haven't, and I'm the one who did it, if I haven't been able to get a gross toe removal and a remission in that patient, I'm not going to do it the 3rd time or the 4th time. So I become less and less aggressive with multiple surgeries and use radiation, because as much as I know as surgeons, we somehow don't like radiation, but radiation is a viable option in pituitary tumors with good results.
Okay, thank you.
Any other question?
Nadia.
Yeah, please. Well, I have a question in the same way. Did you have some cases when we operate first, you have a reduced surgery, for example, and go after radiosurgery? Did you have some case like that?
To go immediately? I didn't understand, Naja. You
Not
mean after
immediately,
surgery?
when you have to repeat surgery after the first surgery and radiosurgery.
After the first surgery, it's rare, that I would do radiation. I mean, if it's as I saw in the other one that had significant residual, that you might do it. But generally, I will observe the patient. If the lesion is in the cavernous sinus, we know that some of these are indolent; they will remain there and not go. So I like to see that there is evidence of progression, and then I will consider radiation. But that is a good, and it's controversy, as I said. Generally in US, and Ed will maybe correct me, that the general feeling is that the ones that use radiation will generally go fairly quickly to radiation if they see that there's residual. Whereas in Europe, generally they will wait and see that there's progression and then consider radiation.
Okay, thank you.
But I think this is a very important point. Once you see there is some residual tumor, maybe cavernous sinus or wherever else, how long do you wait, or do we wait until radiation therapy? I try to, delay in as much as possible radiation therapy, mainly if the pituitary gland could be in the radiation field, because the rate of hypopituitarism is no less than 60% at 5 years, not less than 80% at 10 years. So my policy is just trying to delay in as much as possible the indication for radiation in this remaining lesion. I don't know your policy regarding that.
So the issue there, Miguel, is that the radiation oncologists, and they've done some studies, and I don't know, how valid they are. They suggest to them that at least is that the if you delay it, the results are not as good as if you do it up front. Now I don't know if that's a way of getting you to do the radiation. I don't know. But in the literature suggests some of these studies that that delaying it and then just doing it when they start, that is not as a good outcome, but still good, but not as good as if you did it up front. But I don't have a complete answer to that.
Thank you very much. Right. So, well, I think we have to move on, and in behalf of our big chairman, Professor Imad Kanan, I'm going to hand over to Dr. Sanjeeva Jijaritna for the presentation of the next speaker, and go on, please.
Miguel, thank you very much. It's a real honor to host this session with you and Imad. I can also confirm that here in Oxford, we have bleeding cavernous sinuses, just like you do in Malaga.
Yeah.
I've been very impressed by all of the speakers. I've been really enjoying it. It's been a fantastic session so far from all our speakers. And thank you, Imad and Vladimir, for organizing this. And continuing along the same vein, we now have Professor Naja El Abadi, who has been the professor and chairman at Ibn Sina Hospital in Rabat in Morocco. She's the chairperson of the WFNS Women in Neurosurgery Committee. I believe the president of the Moroccan Society of Neurosurgery, a huge experience in skull-based surgery and pituitary surgery. So we're very pleased, Professor El Abadi, that you've been able to join us today. So thank you very much for coming, and we look forward to your presentation.
Thank you so much, my friend. And I'm first of all, my congratulations to Professor Ahmed for this wonderful webinar. And also I would like to thank all my colleagues and friends today who are involved in this amazing webinar. And also my thanks to the WFNS Neurosurgical Anatomy Committee to set up this tremendous and webinars from many months now, and the great job that they are doing to gather such experts of this topic. I'm very
think we lost you there, Nadia.
Honor today to have to now. Are you hearing me now?
You're back. You're back now. We lost you earlier, but you're back.
Yes, yes. I know, because I share my my connection with my mobile, so I will. Okay. And sorry, it always I say a great pleasure to meet you again, especially during this hard time, and even if virtually. And thank you again for your very kind words. And my talk today is about management of complication and endoscopic pituitary surgery. So it seems for me more relevant to speak about pitfalls and how to avoid complications in endoscopic pituitary surgery, and therefore management. What's happening? Here my university, I'm working, Apoplexy University, and my hospital here, Sheikh Zayed Hospital, when I work in Rabat from more than 10 years ago. We were interested to see how to reduce the complications by following the different steps of the procedure and taking into account the experience accumulated in endoscopic pituitary surgery, and highlighting the message to remember to smooth the learning curve, avoid complication, and those, of course, improve results. So today, as already said by all my predecessors and my mentors, we should consider the endoscopy as an important tool in the armamentarium of the skull-based surgery. And as you know very well, and repeat by all of you during this session, and also during this weekend, during the endocrine WFNS endocrine neuroendocrine committee, the endoscopy pituitary surgery has emerged as a better alternative to microsurgery. Paulo showed us very well the advantage of course of endoscopy regarding the microsurgery has distinct advantage, provide better visualization, avoiding functional disorder, respiratory chain, rhinitis, etc. This technique needs endoscopy anatomy knowledge. Is very important. It's emphasized by many of you, and the learning curve with the ENT, in my humble opinion, is very, especially on ENT endoscopic surgeon, is very important to start this approach. So we need more than 50 procedures from my view for pituitary adenoma to control, to master this approach or more. And the selection of the patient is very important for successful outcomes, especially in the beginning. So they are summarized in the following schema. The microscope provides a tubular view, as you know very well, whereas we have a panoramic one with the endoscope. Illumination and the magnification are better. It's a panoramic, wider view, close-up view with endoscopic, as you know very well. And this is a better distinction between tumor and normal tissue. We show us that many presentation, and looking around the corners, we see what our friend from Japan to show us how he can go from cella to cavernous sinus below, but we need to know very well, to have a good knowledge of the anatomical landmarks is very important for this surgery. Changing from microscope to endoscope may be difficult, and discouraging sometimes. Do not change suddenly, change slowly. Initially, if you are use the sublabial, you have to move the first to the endoscopic assisted with the retractor, and then without retractor. So a slow progress in a stepwise manner brings confidence and ability to tackle complications. So following the different steps of procedure, some complications could be expected. We will see some of them linked to the endoscopy, and we will skip off the others, the common with the microsurgery, such as endocrine complications, because the time also it's not enough. And they include vascular injury, nerve injury, and nervous system and infection. Among these, the consequences of internal carotid artery injury are the most serious, and its mortality, as you know, and disability rate are very high. So the recognition of important landmarks during each of these stages is the key for safe exposure, and therefore avoid the complication. Paolo and Fred show us very well this different step. I will skip it, and I will just talk about some complication. For the first for in the step nasal step, for example, we need to avoid injury to nasal mucosa during insertion and removal of instruments. Resultant bleeding can be very frustrating and better controlled by saline infiltration than coagulation. Our protocol to avoid the bleeding, which is used in the common used by the most of neurosurgeons worldwide, we need the cooperation of our anesthesiologist to keep the blood pressure relatively low, around 8 to 10. And the bleeding during this approach is really the great enemy. You know that very well. And sometimes there is a synergy, as you see here in this video. There is a synergy that we can see it in some cases for the first time, because there is some infection before the happening of the pituitary adenoma, but more frequently we see it after reoperation, and we should to cut it with the monopolar and not to cut it sharply, because it can be recurrent if you cut it with the knife sharply. So learning the approach requires collaboration. I already said that, with the ENT, who are more used to preserving the endonasal structure, reducing the risk of complications, and facilitating the possible surgical revision, avoiding injury to mucosa during insertion and removal of instrument. And I have to say, I remember when I have started my neurosurgery 30 years ago, assisting some surgeons with an important injury of mucosa, and have seen a patient after following them years after, while with a huge complication like emptying the feeling like empty nose, described by patient as unbearable and difficult to breathe. And this approach could be a frustrating experience in the first 20 and 30 cases, because of difficulty in initial phase of procedure, which can be minimized, overcome, or avoided by knowledge of endoscopic equipment, detailed understanding of endoscopic perception of anatomy, learning endoscopic skills, and knowing tips and tricks. Microsurgery is like eating with fork and knife. Endoscopy surgery is like eating with one chopstick in one each hand. So we can learn this approach only with commitment and dedication. The second stage, the sphenoidal stage, in this second, it means sphenoidal. In my humble experience, the surgeon and assistant act as a team, as a pilot and co-pilot, better than fixing scope in holder provide. It provides better perception in this step. I'm completely agree with Paolo when he said that. And first of the bone plan, a scanographic study being derived to avoid the traps of apneumatization of sphenoidal sinus. In most cases, you know, the sphenoidal sinus is largely pneumatized and access to cellular floor is not a problem. However, in some cases in sinus, the sinus is partially pneumatized and are not at all, which requires use of drilling and makes useful the use of neuronavigation. And it is also indicated in the early cases, the giant tumors and the kissing carotid, for example. And a good study of per-operative imaging can anticipate this kind of problem: assessment of size of nasal airway, deviation of nasal septum, anatomical variation of nasal pathway, sphenoidal sinus, sella, etc. So the first complication in my opinion is when we are faced multiple septa and the sphenoidal sinus may distort the perception of the midline. And this is one of the first cases in my series where the procedure was stopped and switched to microsurgery because of the difficulty of visualizing the stable anatomical landmarks, optical nerves, carotid, etc. And at that time, we didn't have neuronavigation. Recognize the anatomic trend endoscopically, the two optic nerves of the superior part and the two superolateral internal carotid and two sinus cavernous laterally, and also morphological study in MRI is in pathological situation is very important. And we see our colleague from Japan show us for this case, I don't go to the sinus cavernous sinus. I just perform partial removal of the tumor and send the patient to radio surgery. Because I never I don't have experience with surgery of cavernous sinus. This is another case, very interesting, because it's a woman for 67 years which had a severe visual defect with non-functional pituitary adenoma, and the MRI showed the infiltration, the invasion of the left cavernous sinus. And we have the fun spotting with my colleagues, the carotid on the preoperative plan here, especially in the left and the neighbor structures. So this is the video of these patients. The opening of the sphenoidal sinus sometimes require a drilling to better see the anatomical landmarks. You see here, of course, the vomer, the rostrum, and there is we use the drilling because it was very strong. And sorry, it's yeah. Here is the sinus is open partially. We continue the opening with the Curison, and I go next one. So here is the image in front of which we found ourselves during the opening of the sphenoidal sinus of the unrecognizable anatomical landmarks. It's thanks to the narrow navigation that we had the audacity to open these septa here to find the midline and the cellar floor. You can see here the proximity of the two carotid by looking at each time the neuronavigation, and therefore the damage of carotid injury is very important because the venicity and the proximity of the two carotids. The sphenoidectomy, usually in this approach, we need to be enlarged immediately and to avoid erroneous entry to anterior cranial fossa. And sphenoidectomy usually is made as a V-shaped from both ostia by diamond drill, as I told you before, or removed at a single piece, as you see here, and then the open of the cellar, and you see here the dura. So you can see also the cellar floor after drilling the various septa here and tracking by neuronavigation of the midline and the imprint of the two carotid. You see it here laterally, and when you executive in and out movement inside the nasal cavity to judge the depth and to fix surgical landmarks, we need to be very careful, because we example in some cases without neuronavigation. In this case, we can't. Okay, we can't move more. At not properly oriented Doppler or navigation, helpful must be recognized immediately and treated by endovascular stent. You must, when you are in front of carotid artery injury, I think you have to first calm down and then pry if there is an endovascular radiologist available, control hemostasis either with the cotton wool and take muscle near be it the situation, allow it, then packing on all and call to of course the endovascular to tackle this complication. Carotid artery injury is the most feared and potentially catastrophic intraoperative complication, and an endoscopic skull-based surgeon may face. With the advancement of transnasal endoscopy surgery and the willingness to tackle more diverse pathology evidence-based management of this treating complication is paramount for patient safety and the surgeon confidence. Review of the when I reviewed the literature, we found the incidence of this complication in endonasal skull-based surgery to be as high as 9% in some surgeries. Furthermore, current treatment recommendations can result in damage to critical neurovascular structures. Management decision must be made in the pre-operative, operative and post-operative setting to ensure adequate treatment to carotid artery injury and the prevention of its complications such as pseudoaneurysm in phases should be placed on a surgical competency, teamwork, and the technical expertise through education and the training. Don't forget this image. It's really one of the image, the panoramic view mimicking a fetal face You don't go over if you don't have this image before and control and have all the anatomical landmarks. So here the neuronavigation is very important in many situations for the beginner, early cases, when they have a sphenoidal sinus anatomy not straight, pericellular or concal type, or multiseptal, as I show you, in an extended transsphenoidal procedure. In the giant tumor, as Fred showed us, you have to pass the scope in the nostril inferiorly 25 degrees to choana first, and choana, you know, is an anatomic reference, and then go up between the inferior turbinate, middle turbinate, and septum. Paulo showed us very well this step of procedure, and the scope is held upper part of nostril. Deforming it, its instruments are passed below the scope through a lower part of nostril, and keep chicken proper orientation is very important. Buttons of endoscope are facing off the screen all the time, and especially after each exit and insertion. Midline identified by remains of rostrum, vomer inferiorly, and stay between the carotid bulges. And if you have problem, don't hesitate to use the neuronavigation. So when we are face reoperation, I will share with you these cases. We pass scope on the nostril for 25 degrees to choana, as I said before, and we try to find the midline to identify by remains of rostrum, as I said to you, vomer inferiorly, and then we have to stay between the two bulges. Here we don't. I pass by the see how the situation, where is the some anatomical landmarks, and I was really obliged to use of course the neuronavigation to identify the midline, and then here you see after identify the rostrum here, and then we identify finally the dura, which is a very fibrosis. You see here, I'm trying to cut it, but it's not easy. And finally, of course, continue the operation with the removal of the tumor. The next one is the cellular stage, is the last one. The opening of the dura first is very important. The endoscope knife is used to cut dura in the center of from periphery to midline, not midline to periphery, as with the long handle of knife. Precision is not very accurate and can injure cavernous sinus. Or use precision grip scissor to extend dural cut on the side after initial central opening with the endoscope knife. Opening is extended caudally and obliquely toward 5 and 8 o'clock position, creating inferior flap, and cut dura only, not the tumor capsule. Dissect dural flaps from the tumor and reflect them outside. Basal and posterior part of tumor is removed from opening the inferior flap in a posterior trajectory toward the clivus and the dorsum sali junction in caudal to rostral direction, first to avoid to remnant and normal tissue of pituitary gland.
2
So
minutes,
the cellular
Dr. Najia.
okay. I will go faster. The cellular stage start by this. I will use this video first. Maybe this one. Start here. Okay. So the cellular stage start by pushing the diaphragm with the cottonoid and remove tumor using a curved situation from recess and recess under vision with the angled scope, bimanual dissection of capsule, section forceps in left hand and for gentle retraction and precision grip forceps in right hand for counter traction and dissection to peel away arachnoid of adherent normal structure. So I think I will go faster because the pulsation, when the pulsation is visible in the diaphragm, is the robust finding that there is a total tumor removal. If arachnoid tear occur, prevent further opening of arachnoid. Small tear should immediately be seated with the glue and keep on one patty to cover to prevent blood going in a subarachnoid in space and causing vasospasm. So the last stage is the reconstruction stage. I think Professor Paolo Capabianca told us many things about that. So I just maybe tell you that there is if there is the CSF leg persists, we need to in our experience we reoperate immediately. The 3F that he said is very judicious, and meningitis is, as you know, a dangerous complication and has an incidence of 0.4 to 9%. Certainly, a postoperative CSF leg is an important risk for factor for meningitis after surgery. In addition, the presence of significant preoperative paranasal sinus abnormalities also carries a significant risk for meningitis with the transsphenoidal surgery. Another but rare complication of postoperative CSF leg following this approach is a tension of pneumocephalus and meticulous closure of the cellar, as already said. Defect has been advocated to prevent complication. So in conclusion, all in all, what we can say that the majority of post-operative complication can be avoided by gradual transition from microscope to endoscope. Proper selection of cases in the beginning is very important. Acquiring hand-eye coordination and endoscopic surgical skills in lab on cadavers or assistant experts. Gentle handling of mucosa. I'm always telling to my collaborator it's very important. Spending time in sphenoethmoidal recess widening and regonation of important landmarks during each stage of surgery is very important, is crucial. Bimanual dissection and sequential tumor excision under vision, using extended approach in large supracellular and giant adenoma, as Fred shown us, and image guiding in the first, in my opinion, for 50 cases, and will never required, of course. Mucosal flap in reoperation is mandatory. Avoidance of arachnoid tear, we have to do our best to avoid it, and preservation of normal pituitary. So expertise in both open and endoscopic techniques is necessary for the contemporary skull-based surgeon. And thank you very much for your attention, and sorry to be so long. It's not easy to speak about all the complication of this approach in 25 minutes. Thank you so much.
Thank you very much, Nigel. Thank you for an excellent talk. Some really nice practical tips for people who are starting out. And also a nice description about staying calm, which is maybe the most important thing when dealing with some of these complications. Are there any comments from anybody else on the panel? Any questions for our speaker, please? While we're waiting, I'll just ask a question. It's always difficult, isn't it, to try and train to handle serious bleeding like the carotid or anything like that. What are your thoughts, or for anyone from the panel? How do you prepare for something like that? If you do enough complex cases, you are going to get some sort of problem, vessel injury, either the carotid.
I had in my career, I think, because I show you, of course, in this series only the endoscopic approaches, about 150, but I had more experience with microsurgery for 10 years before. I have more than 300 cases. I have two complications with the carotid artery injury. The first one when I operate with the microsurgery, I have the chance. I was lucky at that time because I have endovascular surgeon in the room near me, and of course I have some mucosa that I put it in on the injury of the carotid, and some hemostatic and the packing, and then we repair it with the endovascular. And the second one is happened, I think, 2 years ago, and I have also in this time my endovascular just behind me, because I expected before operating that we can have maybe that the injury of carotid artery can be happened, and we prepare the carotid also sometimes in these cases in the neck for in case when we couldn't repair or control the bleeding.
Thank you. Are there any comments from anybody else from the panel?
Sanjeev, I'm driving, so may I ask a question?
Of course.
That I think Prof. Naja's talk was quite good, and lots of pearls of wisdom in there. Especially, I just want to emphasize the importance of landmarks and orienting yourself to the midline and not depending on too much on navigation. I know these days we use navigation for all these cases, and partly it's because we are worried about the medical legal issues as well. But I agree. I think in a primary case, the more emphasis should be on your landmarks, knowing your landmarks and sticking to the landmarks, because even a few millimeters of inaccuracy with the navigation system can land you in trouble. But I think it's quite useful in a recurrent case, and when there is no landmark, it's quite useful. But I think your primary emphasis should be on the your landmarks and anatomy, as Prof. Naja eloquently said. Thanks for the great talk.
Thank you.
Thank you. Well, thank you again, Professor Al-Abadi, for joining us.
Thank you. It's my pleasure.
Now it's a real pleasure to introduce Professor Kanan. Now, you've been joining us for our WFNS seminars that have been going on for almost a year now. He really doesn't need an introduction, but as you know, he is an extremely experienced skull-base vascular surgeon. He's the chairman of King Faisal Hospital and Al Faisal University professor. He's the chairman of the WFNS Neuroanatomy Committee. He has been spearheading all of these webinars that we've been having, putting together the programs, managing to rope all of us to come along, doing an extremely hard job there along with Professor Bennett. So it's a real pleasure to introduce Professor Kanan, a real expert here in pituitary surgery. We'll be talking to us about the very difficult topic of Cushing's and pituitary surgery. Thank you for joining us, Professor Kanan.
Thank you, Sanjeeva, for giving me this introduction. I just put the timer so I won't be exceeding my time, okay? Well, the talk will be on challenges management of Cushing disease. I'd like to thank all the faculties and the invited guests for the contribution. I learned a lot and I'm still learning from them. Harvey Cushing, we call him the father of neurosurgery. His first case of Cushing was the little Minnie from New York, where he introduced the case in 1912 as a basophilic tumor. 20 years later, the group in Oxford, where you are, and Dr. Sanjeeva, they found cases similar to Dr. Cushing, and they decided to give him the credit to call it Cushing disease. So Cushing disease was initiated by the group from Oxford. And of course, Cushing syndrome, when the lesion is outside the pituitary gland, and it was reported by Bishop first time. There are a few
we're not seeing your screen. I'm sorry to interrupt. We're not seeing your screen. If you could just share with us, please.
Okay, let me see. I don't know why. Let me exit and come in again.
Perfect, thank you. If you're having problems, we will send Pablo Gonzalez to your location, so don't worry. Pablo, start running.
Sorry, Sanjeev, are you having problem in sharing the screen? Or?
Yeah, I think we just have to, maybe you might just click the share screen at the bottom. I'm sure you've done that already.
Let me just quickly have a look. I think share screen is enabled. Pablo not online?
So while Professor Kanan is just doing that, are there any comments anybody wants to make on what we've heard so far on complications? I think a lot of our participants are probably in the early years and starting out with endoscopic surgery. Any? Professor Gentili, what about you? Any tips you'd have here in the early years of starting out? Sorry, you're muted, I think.
I think, you know, there's a learning curve as we've learned, and this has become, you know, something that everybody talks about, and there really is. You know, when I went from microscopic, and I did a number of microscopic to the, it's not an immediate thing, and I think Naja did it very nicely, that it takes time, it takes a number of cases, and it's just a matter of, you know, being aware anatomy, and I keep saying that is anatomy is surgery. And in terms of complications, to me is anticipation. And I think the complication that I've seen in terms of carotid, and I have to say, I touch wood right now here because I've not had a carotid injury, and that's either because maybe I'm not aggressive enough or whatever, but the ones I've seen was lack of preparation, not being prepared for it, and lack of anatomy, going to place that they had no idea, where they were going. So I think knowledge of anatomy is critical in surgery, regardless of what approach you're using, and anticipating your complication, that this can happen. We think we go on and say this cannot happen, things can happen. So I think anticipation is very critical.
Thank you. Professor Benes, what are your thoughts? You do a lot of difficult vascular cases. I think the principles are applicable anywhere, aren't they? We're talking about trying to anticipate, prevent, maybe staying calm during complications. Vladimir, you're muted. What are your thoughts on people who are starting out early on and managing complications? You're still muted, Vladimir. Oh, maybe he can't hear us. Sorry. Okay. Who else? Miguel, you're here. Miguel, you also do a lot of these very, very complex cases. What would you say to somebody early on in their career as a consultant or attending?
Sorry, excuse me, because I was answering an urgent phone call and I missed some part of
Yeah,
your.
Miguel, he said,
discussion.
I think I can answer if you.
Yeah, Nacho, let's hear from you and then we'll hear from Miguel. We're talking about advice to people early on in their career.
Yeah.
Of dealing with you know, situation we're all going to end up in. If you do enough difficult cases, you're going to run into problems.
This is why I said in my talk that the selection of the patients is very important. You have to select the simple patients when you have you need your scan to study your especially your sphenoidal sinus, no septates. Very difficult sometimes to have the midline and the use if they have of course some neuronavigation is better in the beginning for them, at least for the 21st cases is very important. But the key is to start with the sample cases. The selection for the patient is very important for the beginner.
Absolutely. Well, I think that I cannot be more in agreement with you regarding the selection of the cases for the beginning. And I think that one regarding also the issue of neuronavigation at the very beginning can be helpful. Our policy is just using neuronavigation only if we have a conchal cella or we have a flat cella or in reoperation cases as said before. And regarding the young colleagues, I think that in this particular way of doing operation, I mean endoscopy, the learning curve is crucial. It has been discussed about how moving, Naya, I think you asked Professor Loss how to move from microsurgery to endoscopy. I did this journey more than maybe 12 years ago because I had been working in microscopic pituitary surgery for more than 10 years. And then I have to move to endoscopy because I knew it was the future. Now is the present, of course. So what we did was a gradual, let's say, a conversion, starting with easy cases and just starting with endoscopy. And insofar as the operation was very lengthy, we got lost or there was excessive bleeding, we just put the speculum and continue with microsurgery. This is the way we did, and we did analyze our first 100 cases. And according to that, at the beginning, we used the microscope. We divided it into 5 groups of 20 patients. In the initial 20 patients, we put the microscope maybe in half of the cases. In the last 20, we didn't use the microscope. It was more or less our progression, our transition from microsurgery to endoscopy. I
am with you now, guys. Do you hear me?
Yeah.
Yes.
Okay. So tell me whenever I can start.
Okay.
Perfect. No, well, thank you very much for all those comments. I saw Professor Laws, maybe just briefly, if you just want to give the final comment, and then we'll go to Professor Kanan's talk. Your microphone.
Yeah. I'll just comment on how I did it. So I went to visit Paolo Capabianca and I watched them do the endoscopic approach and understood what the instruments they used were like, and then went home. And I did 100 cases and 14 of them had to be converted to a microscopic approach. After those 14, it's very seldom. Now, sometimes if we get excessive bleeding from the nasal structures, we will actually convert to a microscopic approach, but it doesn't happen very often. And as I mentioned earlier, one of the ways of stopping the bleed or halting the bleeding is to have the table set up so that you can raise the head of the bed so that the thorax is elevated, and you can use the mechanics of the table to raise the head, lower the intracranial venous pressure, and that makes all the difference in finding bleeders and getting them stopped.
Perfect. Well, thank you very much, everybody. Now we're back to the final speaker, Professor Kannan, the chairman of our committee. Thank you. We've got your screen now, and thanks everybody for your comments.
This is the most important picture. I missed to show it, which is Harvey Cushing, that Professor Ed Lowe's like it very much. He has a nicer one than mine color one. And I mentioned about the little mini from New York. That was the first case Dr. Cushing diagnosed with this basophilic tumor. And in 1912, 20 years later, as I mentioned, the group in Oxford, where Dr. Sanjeeva is coming from, has reported similar cases, and they tagged the name as a credit to Professor Cushing to call it Cushing disease. One more thing, comment on the previous discussion. You see, conversion of a procedure from one to the other is not religion. You can still do it, and you should do it, and you should be embracing a new technology, but eventually adopt what is fit in your practice. That's my message. There are different issues, chronical, they have been mentioned by the previous speakers, but something related to Cushing disease. You see, adrenal cortex was 1855 was first described by Edison. And there were many discoveries and nomenclature came over the years from Nelson syndrome, cortisone discovery. They are all important in the history. Where on the surgical part, transfemoral surgery, we have been listening for the last 3 days from the Neuroendoscopic committee and from my committee here with about the evolution of the procedure from Stoffer all the way to Dr. Julius Hardy, where he coined the procedure transfemoral surgery, and he coined in 1968 the microadenoma, which is an essential part in the diagnosis of Cushing disease. But on the endoscopic part, of course, Gio was an avant-garde in our book for the endoscopy. There were many others. And I put Hardy's name, although he was not an endoscopic surgeon, but I recall when he came to Vienna to celebrate the 100 years of Pituitary, he came and he said he has an endoscope for $1. And he raised that small mirror from his pocket and said, "This is my endoscope." We start all laughing. But at that time, it was a valuable tool. And I remember we used to use it to look for the tumor up in the suprasellar area if there is any residual. And I'm sure Dr. Ed Lowe's and Dr. Falbush and Fred, they knows about this one. Of course, the endoscopy, I like to thank the group from Pittsburgh and Napoli. They were the avant-garde in promoting this technique. 2 credit comes, one to Professor Hardy, coining microadenoma. And this make a difference in the management of Cushing disease. As we know, Cushing disease in general, they are microadenoma rather a macroadenoma. And somebody was neglected completely, but I like to put his name. He is from Bristol, Professor Griffith. He is the one who published in 1987 the direct approach that we are all using it. To avoid all the complication from the septum, for septum perforation and integrity of the mucosa and the nasal cavity. Professor Griffith was a great guy, but a humble person from Bristol, and I'd like to give him the credit on these things. Cushing disease, of course, we have to categorize in pediatric. Is not like in adult. Most of the cases in pediatric, they are more aggressive. They are macro, more in percentage. They don't have the gender difference, where in adult is completely the reverse. There are different criteria to make a diagnosis. I'm not going to go over this. Surgeons that don't like to listen this one, but I always say a good pituitary surgeon should be a good endocrinologist. If you don't know the pathophysiology and the physiology and the feedback of all these hormones and their relationship, you won't be making the right judgment for immune management. The same like you should have be a friend of the ENT colleague, you have to be a very close friend because they will supply you with the case. and you should have an aggressive endocrinologist and minimal invasive neurosurgeon. And there are different diagnostic tools. They are give you, you see, the sensitivity and specificity of all these overnight suppression tests. They give you a percentage of 90 to 100% specificity. And more recently, we heard that there is even the saliva cortisol test 8 hours after the suppression test. It gives you a higher sensitivity. It might be the future. But even with all these lab tests and SATH, imaging, although is condoned sometimes in Cushing disease, in microadenoma, there are a percentage, at least in some report, up to 30% you cannot see the microadenoma, and you have to be dependent on some lab studies that I will talk about it. But again, there are different radiological images to make a diagnosis of microadenoma. And this is, of course, pituitary is one of the P's that has no B's. That's what I teach my resident. This is the pineal region, the pituitary, the plexa postrema, they don't have blood-brain barrier. So you advise your neuroradiologist or the radiologist to do the imaging immediately post-injection so you can spare or show the microadenoma. There are different modern technology to show it with the molecular imaging now, more recently and trendy. Anatomy of the sinus is very important. That's the value of CT scan. Here on MRI, you see the septi within the sinus, they are not always a midline. There are different septies. That's why I still believe the main point mentioned, the landmark, and reported as mentioned several times today, and Lowe's mentioned midline structure is very important. You should not lose it by the orientation. That's, I still believe myself, I'm against all the odd. I still like to go through the rostrum and midline. I don't like to go through the ostium. The ostium is not a good landmark to start with. The ostium, you have to lift a little bit the superior turbinate to see it. You are coming more lateralized, you see part of the cella. Where if you go midline, this is the actual midline, and then you can extend it to from one ostium to the others. Especially when you are doing a recurrence. There is no ostium. The ostium has gone with the wind. No, you drill it. So you have to go to the midline, and the nasal crest or the sphenoid crest is always there as a midline. You keep it as an orientation. And you see here the chamber. If you go in the right chamber or the left chamber here, you are ending in the cavernous sinus before you start even on the lesion. And the lesion is just here in the next to the midline, next to the medial wall of the cavernous sinus. And you see it is very small lesion in this one. You have to recall as well, there are several reports, and we reported that it's not always within the cella. Sometimes is infracellular, sometimes behind the stalk, sometimes on the medial wall of the cavernous sinus or under the diaphragm. And in the old days, I say, what is the need for the endoscopy in Cushing? I can do it without. But I realized the evaluation of the gland and seeing the gland from near vision, you might be able to discriminate sometimes, and it helps you. Or to see this blind corner with the endoscope if it's needed. So we use the PET scan in the negative MRI studies, and we realize 25% of MRI negative Cushing disease documented by lab studies, but we failed to lateralize, we were able to have a positive PET scan. And I think the daughter of Professor Miguel Reyes has worked on this one even more advanced than me, because I remember attending her presentation last year in Malaga, and she showed even a more updated result on this one. So remember, if you have the facility and you fail to lateralize, then it's very important study if you don't want to go into invasive procedure. Inferior petrosal sinus sampling is a technique we've approached it when we fail to identify, to lateralize. It's as published by the NIH, gradient more than 3 is a lateralizing one, and it can be a centralizing one, and you can discriminate it from the ectopic. But remember, sometimes you get contamination from the contralateral side. The intercavernous sinuses, they can be very prominent. You contaminate from one sphenoid sinus, petrosal sinus to the other side, and you should be aware of it. And you should have a good interventional radiologist that he put the catheter in the right spot. Otherwise, if he put it in the jugular bulb, you are contaminating from the other side, and the results are not counted. So this is the challenge of exploring a pituitary gland where there is no visual adenoma on MRI. So it's a technical challenge because you have a small cella, you need to expose the whole pituitary gland. This is a very important part in Cushing disease. And of course, you have to deal with the bleeding from the basal dura and from the cavernous sinus once you manipulate it. Abnormal tissue sometimes is difficult to recognize, but in several recent reports that the endoscopy with the near vision, it might give you some discrimination by visual impact. So the goals of operation that was described in Cushing disease are two specific things. You have to be selective in the resection, not ablation of the gland. And the other things is the preservation and restoration of the pituitary function to the maximum. Of course, all others apply to all pituitary tumor because Cushing, as I said, they are usually micro, but decompression of the optic is one of the options. So if you do the right job and you do selective resection, that's what you get. This is pre and post. You see, this patient was reported as partially empty cella, but we saw that small lesion and we highlighted on PET scan. This is pre and this is follow-up 5 years later. Now, when it comes to the challenge of the approach, this is the big discussion, microsurgery, endoscopy. I always say all the road goes to Rome. And I stress the point, I like to go through this silly nose, the nasal crest. This is your midline. Don't go through the windows, through the eyes, because especially in the recurrence. And this will be really least invasive because you don't need to touch even the septum. At the back of the septum, you do your incision if it's needed just to make a flap. And you decide about the mucosal septal flap to the size, you tailor it yourself. And then you deflect the septum to the other side. I have staged the procedure, the transsphenoidal surgery, into 4 phases. I call the nasal, sinus, cella, and paracella, and the supracella. This is the stages I stage the procedure. And this is a small technical note I have improvised. One thing I have to say, and I stress it over the years, using the speculum is not a sin. I have never had problem with the speculum. People may make a big fuss about using the speculum. I use it at the beginning because I open the door for myself. I do the incision on the posterior part of the septum, make the mucosal flap. Then I displace the septum to the other side, and through the contralateral nostril, I pass a dissector, penetrated dissector, and I enter the scope. You see the tip of the scope here, I know I have my scope. Then I remove the speculum if I don't need it, okay? But it's nothing wrong by using the first phase, phase 1, I call it, the speculum. You will do with your 2 hand feet by dexterities. I do the draining here through the endoscope as I did it here. You see, I'm seeing it from the endoscope. I use my 2 hands, okay? And I do the flap, and this after resection, I can see the herniated this. You see the exposure I'm getting even for the speculum. This is with the speculum, but I put the endoscope to show you what I have taken by putting the speculum. And this is at the end of procedure. I see the middle wall of the cavernous sinus, and I see the elevated, retracted diaphragma celli. This is a small technical note. You are not damaging the integrity of the nose. I hate to do any manipulation on the turbinate unnecessarily, unless you are doing an extended approach, and I don't like this extended approach going in the cavernous sinus. I've seen several reports and several videos from the last 3 days. People go into cavernous sinus, take 10% of that lesion and leave the 20%. And what is the outcome? underreported. I'm sure cranial nerve involvement, I'm sure there are some, the vascular injury I've seen over the last 3 days, everyone showed me 1 or 2 cases of carotid artery injury. I have never witnessed this one in my practice with the practice we are using. Navigation is essential, and I agree with the point mentioned. Now we never use the C-arm unless you are don't have the navigation. But I think most of the places they have a navigation system, and it's very essential, especially in the recurrence cases. You got lost, you need the navigation system. Now the beauty of the navigation, of course, you are not doing interaxial lesion to talk about the shift and all these things. You are talking about skull-based lesion that is vessel on the skull base. So the shift is not a big issue in that regard. Thanks to Dr. Capabianca, who has supported and promoted the endoscopy, and I always like his books and the nice picture he showed. We used them here to show the value of the endoscopy. I'm not saying that we should do the transsphenoidal surgery without endoscope, but I like the hybrid use. There is something called the third option. One option is purely microscopic, the other option purely endoscopic, but why not making the benefit of the 2 facilities? Both are tools, and I think these 2 tools joined together, the end result or the common denominator of the 2 techniques to do a microsurgical resection of the lesion. Use your 2 hands to resect, not only the suction, pulling and retracting, pull and counter, and 2 arachnoid dissection. This is very important even in transsphenoidal surgery. Someone told me, oh, in endoscopic, you don't need microsurgery. I said, then you are on the wrong side. You are not going to give good surgery. Special area to inspect and the value of endoscopy to look to the medial wall of the cavernous sinus, to look to subdiaphragmatic area and peri-pituitary stalk, especially in microadenoma of Cushing, so you can retrieve any hidden lesion. And sometimes this lesion becomes like a horseshoe. One time we operated on one side and I thought I'm done. And there was a lateralization, a microadenoma. 2 years later, I have it on the other side. Then when I went back to the picture, I saw there was a horseshoe appearance of that small lesion going behind the stalk, hiding on the other side. So transsphenoidal versus micro, I call it the endoscopic assisted transsphenoidal surgery. And this is how you see it. You might see it flop or flip. You have to decide and make that decision like this picture. So endoscopic transsphenoidal surgery, people complain that this is 2-dimensional. You can compensate. I have a 3D with the microscope if I need the depth, but most of the time you will manage with the endoscope. And it was mentioned that there is now a 3D endoscope, but it has not got promoted or designed by the company and went further stretched for that one. It should be used by surgeon with good microsurgical technique. Otherwise, it's a failure. Potential for more industrial innovation. That's what I asked Dr. Capabianca. We should go more with the company to introduce more technology. You see, if you want now to zoom that endoscope, or if you want to focus on the scope, it's a nightmare. It's a mechanical and very harsh sometimes. And recently I talked to stores. They said, oh, finally they came with something like the BMW. You can move it from outside to zoom out and in, but it's still not very popularized in the market. A learning curve is a prerequisite, and we heard it several times. CSD was a concern, but I think with the mucosal flap and with the technology has improved tremendously. And I always say the combination is focused on microsurgical. This is a report from COVAX. Dr. Edlos knows him very well. They did the study and they divide them between microscopic and endoscopic. They found no result change in the remission for Cushing disease. Intraoperative, I don't see the indication for the Cushing disease microadenoma. It might be for a giant tumor, yes, but for Cushing disease, not. It's cost, perhaps not effective for many people. If you have the tools, I use it for giant tumor resection. What are the suggesting criteria for remission? one of the feature is clinical feature, a resumal of diurnal variation. This is very important, but might take 6 months. And there are several criteria, I mention it here. This slide, I borrowed from your book, Dr. Lawrence. This is your book on tumor. I like that book you have done. I wish you have an update on that one. You published this one before the era of endoscopy. What was your result in remission in microadenoma? 85%. Not the best one can get this results with all the tools they have. But some of them, Dr. Falbush, his results is in the 80s was 80%. In the 90s, he just reported 2 days ago in his presentation, it goes 80 to 90% for microadenoma first time. So it tells you it depends on the experience of the surgeon rather than the tool. Whether you are using the microscope or endoscope, the difference is the variation not very huge. But where to dig and find the microadenoma, this is the most important. So are there alternative option for no remission? As mentioned, you go again because this is a surgical option, and in 50% you will find the adenoma on the second go. Okay, I mean if there is no remission. Hypophysectomy, we get extended from it, but we are still do the multiple incision if we don't see the gland, and we do multiple vertical or transverse incision and see if we can dig the adenoma. Of course, radiation and bilateralectomy is another, there is medical treatment, but beware of these type. The pathological type became an important type of when to refer patient to radiation therapy. The silent cortical tumors, they are very aggressive. The Rook cell tumor, they are rare, but very aggressive. Cavernous sinus wall invasion by the lesion and high MIP index has been reported above 3+%. Then there are potential for referral for radiation. Radiation has its side effects, and there are different types, but it has some value when we need it. There are reports that caprolactone, which we all use sometimes, my endocrinologist, anything he can give caprolactone, he said it might help, even in Cushing disease, I doubt it. Ketoconazole has improved the clinical status, but not the hormonal profile or the size of the lesion, but they might work as a radioprotective agent, so it might interfere with radiation therapy. This publication came from Professor Ladislau Steiner from the Charlottesville Times, okay, and he has reported not very impressive result, but these are the results with the gamma knife. And of course, the comparison to surgery was not perfectly well because he was using the urine-free cortisol rather than the suppression test, and which is more sensitive. And the follow-up was only for 24 months. And there were visual issues, neurological deficits in 5%, cranial nerve deficits in 10%. Adenoectomy, there is a renaissance for, I call it, for desperate patient and doctors. When they fail all the medication, they go for the adenectomy, and there is a surgical mortality, although they use now the endoscopic procedure to perform laparoscopy, and they will leave it for as an end solution. There are medical treatment, pasireotide, which is somatostatin receptor competitor, is very expensive. I think it's $100,000 for a 1-year treatment, where transfemoral surgery, I think in the state about $15,000 or something like this. So this is not in for average budget countries. So preservation of the gland is the second most challenging situation other than the localization, is the size, location, to see the tumor either on the images or during the surgery. This is one of the influencing factors. If you see it, the result is much better. If you don't see tumors, then whatever you do is not a good outcome. The preoperative function is another factor. We mentioned the pathology. surgical technique and experience, I'll stress this point, and the use of endoscopy, it will help see blind corner. Apoplexy can occur in Cushing disease. This is an interesting case from the long time. Professor Pierre Lagianis used to come to us, and we were discussing the case by chance. He's an interventional radiologist, and we were waiting for our gamma knife to be installed. And this patient has a Cushing disease. She doesn't want to have surgery, but all the lab referred to Cushing disease. Unfortunately, we didn't get the gamma knife. We got the Cyper knife, but 6 months later. By that time, see what's happened. This is the lesion, got apoplexy in it. This is the size of it after 3 months, 6 months, 9 months. This is auto-execution of the adenoma, of a Cushing ACTH producing adenoma. And then we gave Cyper knife to the small lesion. I'm not going to do surgery for the small area. Pituitary carcinoma, they are rare, but they can occur. They metastasize. We have this young lady, we operated twice on her transsphenoidal. There was a cavernous component, received radiation therapy, ended with metastasis to the ribs. And we gave her Timodal for 6 months. All the ribs metastasis subsided. But a year later, she succumbed to her disease. So it's a nasty, unfortunately nasty disease. Two major challenges to repeat localization in Cushing disease and preservation of the gland and management of recurrence. I thank you for your attendance, and I hope I cover some of the aspects. Thank you.
Thank you very much for another excellent talk. Thank you. Let's have some comments or questions from our panel, please.
Dr. Hanan, wonderful talk. Wonderful talk as always, talking about this difficult topic of Cushing disease. Well, actually, there is some concern regarding, in some cases, the exact site of the tumor, because sometimes taking into account that sometimes we have bilateral tumor, and sometimes we can have disease in one side, and the other one, the contralateral one, can be just a non-producing tumor. So according to that, we have been using, and Professor Laws knows about that, we have been using the PET with methionine that seems to have some predictive value just for the location of the tumor. We use that in de novo cases in Cushing disease. We use that in recurrent cases in Cushing disease, and we also use that in this technique in recurrent acromegaly in macroadenoma tumors. Sometimes you have some extension, big extension of the tumor, you make the removal, and you have some hormonal recurrency, and you have an MRI with sonnet scar, and you are not able to identify a small recurrent lesion. So, and we are very happy. We are just in the process of analyzing all our cases, because we have been using that for more than 10 years, and hopefully we can show the results very soon.
Great.
Thank you. I think it's a very interesting technology. Any other comments on this or any of the other talks?
Sanjeeva, this is Fred. Can I ask Imad? So Imad, just you have a patient with Cushing's classic, proven biochemically, beautiful little lesion that you see on the left side, you know, as an adenoma. You go in and you find it beautifully. Do you explore the other side of the gland in those cases where you have? Because that's a question that's always asked, that, you know, but you should always explore the entire gland because you don't know if there's another one. What's your philosophy on that? Yeah. And I would ask Ed Laws, who has had a lot of experience with that.
Myself, I go where the stake is. There is a lesion, I go after the lesion. If there is no hint of involvement on the images and lateralization is very clear to one side, I go on only that side. Because my other issue is the preservation of the function of the gland. this incision is not without an impact on the gland. If it's unnecessary, I don't do it. And that's what I'll do usually.
So,
Iman, could you unshare your screen just so I could see if people are putting their hands up, please?
maybe I could tell you a little bit of what we've discovered over the past year or so. And that is we've had a number of patients that had obvious lesions on the scan, and they most of the time done well. And I do explore the entire gland, no matter what I find, and take out every bit of suspicious material. But what we've discovered is that we have patients with what are called hyperplasia. Now, hyperplasia is under the microscope and with our colleagues in neuropathology, hyperplasia is segments of the corticotroph cells just weaving their way through the normal gland. Often, there'll be a hypointensity in the region of these areas of hyperplasia. The problem is that they're indistinct from tumors. You can't do an extracapsular removal of a hyperplastic lesion. You have to take the rim sometimes of a capsulated lesion. You have to take a little bit more. And with regard to hypopituitarism, I think if you can avoid diabetes insipidus, that's really critical. But you can replace every other hormone easily and not expensively. And so if you have a suspicious area, you can remove it as long as it doesn't produce diabetes insipidus, and you can analyze what hormonal dysfunction the patient may have and fix it. What you can't fix is excess cortisol. And Reinke says, my friend in Munich, who's the best endocrinologist for Cushing's I know, every day a patient with Cushing's has too much cortisol circulating as a death warrant. It destroys the patient. And so you have to take every opportunity to get the cortisol normal, no matter what. And if you don't, the patient's going to have a terrible outcome and a recurrence, and you're in trouble. So that's what I've discovered about Cushing's. It's the most difficult thing we do. And if we have the problem of hyperplasia, which we really don't understand what the mechanism is at all, we have that as a problem, along with tumors that are hard to find, along with extracapsular dissections that don't always work because there's sometimes tumor not within a capsule. So it remains the most difficult thing we have, but always think about the patient. How sick is this patient? What's her life going to be like? Can you make it better? Can you do everything you can while you're there to make it better the first time? And you think about a hypophysectomy. We hardly ever do that anymore because it produces diabetes insipidus if you do it correctly. So we don't have the answer to this. And it's only been since Mini G. We still don't know.
I have one question. Sorry, let me, in that context, ask Ed. Ed, you said if you have a suspect, but we are talking imaging where unilateral. Inferior petrosal, unilateral. There is nothing, it's completely lateralized. You said suspect on seeing the gland from outside. How we would suspect and make the incision in the gland on the contralateral side, based on what we suspect hyperplasia where we have a lesion? Well defined.
I don't know how you can surely demonstrate hyperplasia. It does often look different from the normal gland. Okay. I try to enter the lateral lobe on the side that we leave behind with a soft curette and feel the tissue and look at it. And I do look at everything if we find a typical tumor and everything goes well. But it doesn't always work. I wish it did.
May I say something?
Yes,
yeah, Professor Falbush.
I completely agree with Ed. So it's independent what we are doing from the MRI finding, because half of the patients don't have a positive MRI and you have to look around. So that is one thing. don't be orientated for the MRI. And these tumors are not always round circumscribed. They can have two nodules, one on one side, one on the other side, small connection in between, just in front of the posterior lobe, just in front normally. And then, of course, as Imad said, they can be also extragranular, starting at the surface of the gland, going to cavernous sinus, even outside, or up to the diaphragm, or of course, down in the cellar floor. So I totally agree with Ed. You have to explore the whole cellar content, go around the pituitary gland, even below the diaphragm, look if there is something else. And of course, the problem with the hyperplasia does really depend on your special experience. It's different, I would agree. It's firm, but it's different from the firmness of the pituitary gland. And if you see that, go in. And if you produce hypercortisolism, that's no problem. It's more important to eliminate hypercortisolism. I totally agree with that. Thank you. A short question. The most aggressive tumors I've seen are those who are converted from a silent ACTH-oma to a real ACTH Cushing's. When they are invasive, practically nothing helps. What is your experience?
So Sanjeeva, if I can just say one more thing. Cushing, we all know how incredibly difficult, and we've seen that very nicely. Imad saying, one of the things that I can never understand, and I think a lot of knowledge we don't, is, I have a patient that I operated on, 10 years ago with a Cushing's. Nice immediate drop. Remission, not cure, but remission. Now that patient is in remission for 7 years. And then he has recurrent Cushing. So I talked to my endocrinologist. I said, so just explain to me, what the situation here. He said, of course, you left 2 cells. And those cells now. So I said, what are they doing in 7 years, those 2 cells? And so I have a belief, and I think, in terms of looking at the molecular profile, that these may be new tumors, that these patients have a defect in their genetic, makeup, that we see in a one that has had a remission for 10 years, then has another. That is not the same tumor. I believe it's another tumor that this patient is predisposed to getting Cushing. Now, I don't have any data for that, and we have to look at the molecular, studies on that. But I just still don't understand these long-term remissions and then a recurrence. And sometimes they're not in the same place. They're on the opposite side. That I think gives more thing to my theory. So that's just a comment that I want to make in terms of us not understanding really Cushing's very well at all.
Any other comments from anyone from our panel? Professor Benes.
Imad, thank you. It was excellent, and actually the whole afternoon was excellent. One question, you said, unfortunately, we do not have Gamma Knife, but CyberKnife. And we are installing CyberKnife now. Could you expand on that a bit, please?
CyberKnife is another stereotactic way. You see, radiation oncologists, they like it because they can treat many other organs. This is the comparison as Gamma Knife. When we want to bring Gamma Knife, it will be under the control of neurosurgeons. This is a political issues that always they fight it. And the other things, you can treat head and neck. They extended the neck in the recent years. But you cannot treat pancreatic cancer. You cannot treat any lung metastasis with the pulsation of the lung and inspiration, expiration. And so they feel it's a more cost-effective for them, and they cover a wider disease categories.
That I understand.
But you can give
effectivity.
See, the difference in the drop of the radiation beyond the lesion is almost similar. People has dealt with Gamma Knife, they feel the precision of Gamma Knife more, but in the recent papers, they are almost equal. The best drop of radiation is the proton beam. But who is having proton beam? I think this is very expensive tools. And now a report came, I think 2 days ago, from that neurologist, I think, an endocrinologist in India during the meeting. She presented the worst outcome was with the proton beam regarding the preservation of the normal functionality of the gland and hair report, as compared to gamma knife or to the fractionated cyber knife or conformal radiation. So conformal radiation turned to be in her study was the best for the pituitary gland functionality outcome. So this is
see.
how I see.
So
But
you are happy with
perhaps-
CyberKnife. Your main complaint is that you are not the owner of the Gamma Knife. Am I right? You are a CyberKnife.
Yeah, you see, they used to call us for the cases. Now we refer the cases, they will do this. We used to draw to them the lesion and decide where we want to give radiation. We want to be sure that that's it.
So should you operate the CyberKnife, you would be happy with it?
Yeah.
Yeah, okay. I
Yeah.
just could add something on a proton beam. We have one in Prague, you know, we do not operate it, but I can tell you that since it's in operation, never ever before did we see so many radionecrosis.
Yeah,
As with proton beam.
this is another problem. Yeah, radionecrosis is higher.
Fred, so Victor.
No, I'm saying I'm going to have to leave. Sorry.
Oh, you have to leave.
Thank you very much, everyone. It was an amazing thing. Imad, Vladimir, the entire team, very enjoyable, and hope to see each other again soon, maybe even face to face.
Yes. Well, don't go away. Just 1 minute. We want to take a group picture on the Zoom.
Okay.
Where is Pablo? Is Pablo with us?
Yeah, don't worry. We have our chief photographer.
Yes, I am here, but I think Sanjeeva takes much better pictures than me. So
You
can take your mask off, Pablo.
And big smile, and we hope to see all of you in person.
We have Miguel, Atul, and Rames with us. They are missing.
They are missing, yeah.
Okay, is everybody ready? I'm going to take the picture.
Yeah.
Okay, 1, 2, 3.
Okay, Guy. Thank you so much. Thank you, Ahmed, for your.
Thank you. I think before I conclude, I'd like to give a special appreciation.
Hello.
A special appreciation to Dr. Pablo Gonzalez.
Happy to see you all.
Victor. Take care. Take care.
Congratulations.
Take care.
Take care.
Ahmed, I want to say something. The lecture of Dr. Takeo Goto was really impressive because of the work in the small perforators around the pituitary gland. So it has become clear that the microsurgical anatomy of the paracellular and supracellular region is very important for the development of tumor surgery. In the future, endoscopy will surpass conventional surgery. I think in the future, most of the brain surgeons are going to work with endoscopic. So not only in the cellular region, also in the supra and para. And the knowledge of the vasculature in that region is going to be very, very important in order to preserve the small perforators. Thank you so much.
Agree with you, but we'd like to know more about the outcome of the cases. You see, not only see the technology of it, but know about the outcome. How is these patients doing? As Professor Najia said, how is this patient doing? Did you discuss with them, consented them very well that there are potential they will have a hemorrhage or perforator were clipped? Cranial nerve were affected. These are very important study. We don't see it without out of context of the clinical outcome.
Agree. Thank you so much.
Thank you. Imad, I enjoyed your slide with Hugh Griffiths on it. It was very pioneering neurosurgeon.
He deserved the recognition. Yeah.
I trained in the department he was an attending. I was a resident there, obviously, many years
Oh, I see.
at Frenchy. Anyway, thank you very much, everybody.
Thank you. Take care.
Bye-bye, everyone.
thank you. See you tomorrow.
Bye.
See you
Bye.
tomorrow. Exactly.
See you. Bye, Matt.
Thank you very much.
Bye, Matt.
Bye,
Bye, Vladimir.
Say hi.
Pablo.
See you tomorrow.
Bye.
Tomorrow.
Bye.
Takashi, bye.
Hey, see you tomorrow. I really enjoyed
See
today's
tomorrow.
lecture.
Yeah, we forget to announce tomorrow before we close. Tomorrow is another day, and it will be a very exciting day on the challenges cases, and they are the best dissection of this webinar. So 4 dissection, 5 cases, and we are looking forward to hear about these challenges. And Professor Vladimir will be chairing that session.
Looking forward.
Excellent.